in vaccine research, and I am looking forward to getting a more wholesome overview of the vaccine space and public health. Thank you.
Good morning, everyone. My name is Fumane Lekwala. I'm from Lesotho, born and bred. I work with Future Evidence Foundation, and I'm leading the HPV Evidence Partnership. I'm looking forward to interacting with all of you and hopefully encouraging you to join the evidence community. I'll also be giving a session later this week. Thank you.
Good morning. My name is Alberto Kova from Liberia. I work with the National Public Health Institute of Liberia, Infectious Disease and Epidemiology. I'm also part of the technical working group developing strategies and plans for vaccination in Liberia. I look forward to learning more to help us improve our strategies back home. Thank you.
Good morning. My name is Judith Gishuki. I'm from Kenya. My work is in implementation and research for vaccination around urban setups, and looking forward to see how we can improve equity as well as new developments.
Good morning, everyone. I'm Dieudonné Lompo from Burkina Faso. I'm a medical doctor working in a health district on public. I'm also a student in public health. I'm here to learn about vaccine hesitancy. Thank you.
Good morning, everyone. My name is Ayanda. I work for Afrigen as mRNA research and development. I'm looking forward to learn more about the clinical side. Thank you.
Good morning, everyone. My name is Ritumete Setai. I'm from Lesotho. I'm currently a nurse educator at Paris School of Nursing, where I'm facilitating primary health and also biostatistics and epidemiology. I plan to integrate all the knowledge that I'm going to obtain from this into the development of a micro curriculum. Thank you.
Good morning. My name is Bambara Natogma Usul. I'm from Burkina Faso. I'm a public health manager and practice for the public sector to promote immunization. Thank you.
Good morning, everyone. I'm Joyce Luza from Botswana. Anyone from Botswana here? I'm alone, guys.
No, on the right.
Tepiso. I know Tepiso.
So she's not from Botswana.
Okay. So I'm from the Ministry of Health, working in the EPI program as a health promotion officer. And also I have a master's in public health with disaster management specialization. And I work with the NITEC group, National Immunization Technical Working Group, as the secretariat. So my role in the EPI program is to promote the uptake of vaccines. So recently with the era of COVID, we've seen our immunization coverage is going down. So I'm here to learn more on how innovative issues on how to tackle vaccine hesitancy issues. Thank you very much.
Good morning to everyone. My name is Ntandazo Dlatu. I'm from South Africa. I'm currently based in East London, but I'm a lecturer and a researcher for Walter Sisulu University. And also, I'm also involved in health systems. I'm teaching health systems. I'm teaching quality assurance in medical students. I'm also teaching research methodology to MPH students. I'm also involved in clinical governance institute, which is part of the Walter Sisulu University, because Eastern Cape is one of the provinces that is most affected by so many issues. So clinical governance is, I think, that is the way to go because it incorporates all these problems, the challenges that we're facing in our healthcare system, so that we can promote the quality and at least so issues of immunization. There is also a challenge also in because if you talk about the low income countries, they are facing so many challenges in terms of issues that is in immunizations. So incorporating clinical governance in these challenges that we are facing, at least we can be able to strengthen our healthcare system. Thank you so much. I'm happy to be here. I'm hoping to learn and at least be able to go back and then implement what I've learned.
What are you hoping to learn?
I'm hoping to learn about pharmacovigilance, also the immunization coverages, the support system in order to promote these coverages, what needs to be done in order to able to cover the areas that are unable to be covered in terms of the hard to reach areas, in terms of accessibility, yeah, and so on and so on. So many things.
Just as a reminder, your name, your country, what you do in 3 words, and what you're hoping to learn.
Morning. My name is Lerato Shai. I'm a professional nurse. I'm from Tzaneen in Limpopo. Looking forward to learning more about vaccines and making it more accessible to people that are less privileged.
Good morning. My name is Daphne Ramatladi Mokhadi. I'm from Limpopo and I'm a pharmacist by profession. And I'm here to learn more about vaccines to make them more accessible to our communities and Africa at large, and also to get inspired to study further.
Just before you continue, how many of you, besides those who are from South Africa, how many of you know where Limpopo is? The country. Which country is Limpopo? Yeah, so Limpopo is in South Africa. Okay. All right. Proceed.
Good morning. My name is Komi Akliku. I'm a medical doctor and epidemiologist. I'm from Togo. I work with the government as a health district director. Part of what I do is EPI coordination at the district level. And I'm willing to learn more about vaccinology, especially new vaccine rollout challenges. Right now, my country is launching the new vaccine against malaria. So I'm willing to learn more about all the challenges that we can face. Thank you.
Thank you.
Good morning, everyone. My name is Amina Tujakite. I'm from Mauritania. I'm a consultant with Gavi. Essentially, I want to learn more about vaccine development, delivery system, new policies, just gain new insight about vaccine. Thank you.
Just before you continue, how many countries still get Gavi support for immunization work? All right. So if you have any question related to Gavi and the things they are not funding, you know who to look to.
Yes, good morning, everyone. My name is Fatima Ali Lado. I'm from South Sudan. I'm a medical doctor by profession. I am a project manager with Malaria Consortium office in South Sudan, running vaccine project for GiveWell, zero dose project mobile vaccination in South Sudan. I'm looking forward to learn more about vaccination and moreover to interact and learn about innovation in other countries and how they overcome challenges. Thank you.
Good morning, everyone. My name is Roger Chiza. I'm a medical doctor from Burundi, and I also have an MSc in epidemiology and implementation science. I'm actually working at the National Institute of Public Health, and I'm looking forward to deepening my knowledge in vaccinology and how to increase the compliance with vaccines. Thank you.
Hello, everyone. My name is Fedwa. I'm from Sudan. I'm previous manager of the National Malaria Control Program. And we work closely with the EPI to launch the malaria vaccine in Sudan 2 years ago. So I would be happy to help my colleagues from Togo and South Sudan. I'm currently leading the malaria research group, including the malaria vaccine at University of Khartoum. Thank you.
Sorry, just before we continue, we've heard about what is happening in Sudan. How has it affected immunization?
This needs to, if I want to tell you, maybe you give me 1 hour for this. But in short, we introduced the vaccine around less than 1 year after the war. It was very challenging to go around this. But if I may say, the teamwork made it come true, despite the challenges in the scarcity of the vaccine and unable to make decisions with volatile political and security situations. But now the vaccine has been introduced around almost 1 year, 2 years ago, and we are now working to assess the coverage of the vaccine and all this. And it is not going very well, but it is going to some extent acceptable. Thank you.
Thank you.
Good morning, everyone. I am Mariam Adel. I am from Alexandria, Egypt. I am pharmacist and a PhD holder in diagnostic and molecular microbiology. My work is focused in vaccine preventable disease, immunization safety, and diagnostic microbiology. I am truly honored to be part of this course. And my goals is to advancing immunization program and strength immunization program and public health through collaboration and research. And it is my really pleasure to be part of this course, and I look to learning from you all and collaboration in the research. Thank you.
Thank you.
Good morning, everyone. My name is Lamin F. Manya from the Gambia. I've been working in the area of immunization since 2012 as a vaccinator. From there to be there managing the cold chain system at the district level. By profession, I'm an epidemiologist. Currently, I work with WHO as a research consultant, providing technical support to the regional health directorates in the area of IDSR, integrated disease surveillance and response, and most importantly, immunization operation in the region. What I expect to learn from this is about the introduction of new vaccines, especially in acute emergencies. People keep asking how are vaccines been produced within a short period of time in emergencies. We know the vaccine production take a longer time, and that's been known. But emergency people said, especially when hesitancy comes in, how come vaccines are produced within a short period of time and given to African people, by the way. And I also want to know how do we handle misinformation and disinformation in relation to vaccination. Also the AFIs, that's about pharmacovigilance. Thank you very much.
Morning, everybody. My name is Valerie Mlotra. I'm also from South Africa. I'm an investigator at the Desmond Tutu Health Foundation, so I work on clinical trials. And I'm just interested in deepening my knowledge about vaccinology, especially from a different time point or perspective to where I work in that area.
Good morning, everyone. My name is Richard Lupasu. I'm from Congo. Currently working as a consultant with WHO in the polio eradication program. So I'm an epidemiologist. Yeah, that's what I can say.
Thank you.
Good morning, everyone. I'm just waiting for the screen for my moment on TV. My name is Dasilorenta Nakasha. I'm from, yeah. My name is Dasilorenta Nakasha. I'm from Namibia. I'm working as a lecturer at the University of Namibia. I'm also a member of the NITAC, and I'm happy to be here. At the end of the course, I'm expecting at least to learn perhaps the new research in vaccine and maybe adverse effect. Thank you.
Good morning, everyone. My name is Eric Chitona Kaluli from DRC. I'm a public health professional in VPD. I'm here to learn more about immunization. Thank you.
Good morning, everyone. My name is Nicholas Alexander. I'm from South Africa, and I work together with Africa CDC on behalf of the Charité in Germany to support their capacity and talent development programs. And I'm hoping to understand a little bit more the challenges between coordinating stakeholders in vaccine uptake.
Hello everyone, my name is Aisha Diallo from Senegal, Institut Pasteur of Dakar, and I'm a doctor in pharmacy with a specialization in project management, and I'm here to learn more about vaccine. Thank you.
Good morning, everyone. My name is Peter Njoroge. Oh, good morning, everyone. Thank you. My name is Peter Njoroge. I come from Kenya. I had the EPA program in Nairobi County. I'm here with expectations of expanding my skill set in vaccinology, but also to learn how we can manage the emerging issues around immunization. Thank you.
Good morning, everyone. I'm Eric Mboka Ikum from Cameroon. I'm a medical doctor, advanced FATP graduate. I'm currently working with the government, EPI. I'm in charge of surveillance and response to vaccine preventable disease outbreaks. I'm much more interested in vaccine manufacturing. So I'm here really to learn about the whole process about vaccine manufacturing. Thank you.
Good morning. I'm Tony Biamungu. I come from Djibouti. I don't know every. Do you know Djibouti? Yeah, Djibouti is one of the country, a big country of Africa. So I'm Congolese working for UNICEF in Djibouti. I'm here to extend my network of vaccinology. Thank you.
Good morning, everyone. My name is Rebecca Chitundu. I'm coming from Zambia. I work for the Center for Infectious Disease Research in Zambia, CIDES, where we support the Ministry of Health, the expanded program on immunization. And part of my work is actually I serve as a secretariat in the NITAG in Zambia. My expectations, I look forward to improving my knowledge on vaccines, and especially on the HPV vaccine, where we are seeing the coverage not really improving. So I would like to learn more strategies on how others are actually managing with the higher rates, because we know that that target age is outside to routine immunization. Thank you.
Just before you continue, how many people know who are NITAGs? Just by show of hand. Very few people. Do you want to tell us what NITAGs are? Very briefly.
Okay, so the NITAGs, this is an independent body in most of the countries that supports the Ministry of Health on decision making, evidence-based decision making, to support the Ministry of Health to make recommendation on issues to do with immunization. So every time there's a new vaccine and all that, before a decision is made by the Ministry of Health, the NITAG, I come from Zambia, so we call it ZITAG, Zambia Immunization. Yeah. So the ZITAG will sit and give recommendation to the Ministry of Health before any decision is made on vaccines. It can be vaccine introduction. It can be maybe we want to do a targeted campaigns and all that. Thank you.
Thank you. So after that explanation of what NITAGs are, how many of you would like to be a member of your NITAG in your country? Just by show of hand. Excellent.
Good morning, everyone. My name is Rita Marat, and I am from South Africa, working at BioVac as a key accounts manager. So part of my work includes ensuring that there is sufficient stock in facilities, and I also support EPI initiative in improving coverage. And what I'm looking to learn is improving my knowledge into vaccine, and as well as gaining insights into what is happening beyond South Africa. Thank you.
Good morning, everyone. My name is Rashmika Deeplal. I am a medical doctor from South Africa. I am currently working as a research medical officer for the Desmond Tutu Health Foundation, also working in clinical trials for vaccines. And I'm interested in learning more about the latest developments in vaccinology, as well as how we can strengthen our immunization programs. Thank you.
Good morning, everyone. I'm Mulukan from Ethiopia. I work for the government in Addis Ababa City Administration Health Bureau as immunization manager. And I am here to learn more about vaccine production and how the modern sciences would help us to solve the challenges we have been facing for many years. So I'm very happy to be here. Thank you.
Good morning, everyone. My name is Ewan Noguse. I am from Ethiopia as well. I work at the National Public Health Institute, mainly focusing on cross-border communicable disease control. We have a new initiative on cross-border preventable disease control in our directorate, and I'm hoping to learn innovative and new ways on how we can implement that. Thank you.
Good morning, everyone. My name is Abdurrahman. I'm from Somalia. I'm working as the Minister of Health. I'm a head of a public health department. Yeah, so my expectation is to gain the advance about new vaccines and immunization programs. Thank you.
Good morning, everyone. Sabah al-Khair. My name is Ines Bourzela. I am from Tunisia, Tunisian national, working currently with WHO. I am a medical doctor and a public health and global health specialist. With WHO, I work as a health system strengthening officer, working on a primary healthcare focus and using a life course approach. Some of you, or maybe not, know that Tunisia just introduced the HPV vaccine, and I hope you're not recording because we failed big in the face of disinformation. That's very important. So I'm coming here with the high expectation that we together discuss how to make more resilient systems and more resilient environments to manage, navigate disinformation, vaccine hesitancy, because this is a major challenge now on. Thank you.
Thank you. Morning, everyone. My name is Zed Kwambi from Zimbabwe. I work as the head of the Genomics and Data Science Unit at the African Institute of Biomedical Sciences and Technology. Over the past 20 years, my institution has been focusing on precision medicine, but the first 5 years, our focus has been to incorporate One Health, and that came aboard with the appreciation of branching into vaccinology. So we have started to do antibody production. So my expectation in coming here is to see how we can onboard and domesticate vaccinology. Thank you.
Good morning, everyone. My name is Sikelimpilo Masangwana. I'm from South Africa, working for Africa Health Research Institute as a project coordinator for clinical trials. I'm looking forward to learn more about vaccinology.
Good morning, everyone. My name is Christina. I'm originally from Canada, Russia, but I currently live in South Africa, so I'm coming from South Africa. What am I doing right now? Trying to think about the 3 words. Currently working on my PhD with epidemiology and biostatistics. My background is in nursing, education, health promotion, policy development, and what I'm trying to do here, yeah, deepen my vaccinology knowledge.
Good.
Good morning, everyone. My name is Anele Gela. I'm a research scientist working at the South African TB Vaccine Initiative here in Cape Town. I'm hoping to learn the vaccines program post licensure from this workshop. Thank you.
Hello everyone, my name is Gaëtan Robert Adouaka from Central Africa Republic. I'm a medical doctor and epidemiologist. I work as a consultant at Task Force Global Health to support immunization program and surveillance of vaccine preventable disease across health district. I'm here to learn about immunization program and specific how to reach zero dose children and community health. Thank you.
Good morning, everyone. My name's Charles Kiamutea. I'm from Guinea-Conakry. Actually, I'm National Immunization Coordinator at IOM Guinea, International Organization for Migration. I'm medical doctor, specialist in management health program and epidemiology. Thank you.
Good morning, everyone. My name is Romulus Roto. I'm from in Gabon. I'm PhD student in biomedical science. I am here to learn vaccinology. Thank you. Nice to meet you.
Good morning, everyone. My name is Nomboyo Ngesman. I am from South Africa. I am part of the pharmacovigilance team at BioVac. And on this course, I aim to learn more about the end-to-end life cycle of vaccines, the issues that we're currently facing in the field, and more importantly, how we can try to overcome them. Thank you.
All right, that is it. And now we know you, and we're very, very excited. Oh, there is one.
Oh.
Good morning, everyone. My name is Latif Ndeketa. Hi. Yeah, so I am a third-year PhD student. I'm based in Malawi, so I'm registered at the University of Liverpool. I work with the government, the immunization program for new vaccine introductions, and I'm focusing on improving vaccine evaluation methods post-introduction and how we can separate vaccine attributable effects to other concurrent events that happen at the same time when the vaccine is introduced. So recently I completed the cholera vaccine evaluation, incorporating wash interventions that happened at the very same time the vaccine was introduced during the cholera outbreak in Malawi in 2022, 2023. Yeah, so I'm just happy to be here and to meet you all. Thank you so much.
Good morning, everybody. My name is Nicholas Erasmus. I'm from BioVac just down the road, and I'm actually from Cape Town. The University of Cape Town Health Sciences is my alma mater. So I moved back a while ago from New York. I'm looking at how I can contribute to vaccinology in South Africa. So I'm from the other side of pharma, but recently started strategic delivery. As BioVac expands into Africa, where we want to deliver more and more vaccines, I'm here to learn and to listen to what we can do to help future vaccines come into the company manufactured by Africans for Africans.
Is there one submission?
Ruben would like to take 5 introductions online as well, because we have about 30 participants online.
Okay, who is selecting who is going to introduce?
I
You,
will,
you do.
So we can switch to online. We'll first start with Moronga. You can go ahead. You can unmute yourself and go ahead. Moronga Lorraine.
Thank you. Good morning, everyone. I'm Moronga Lorin from South Africa. I'm working as a research intern at Sefako Health Science University, and I'm also a member of SAVIC, and I'm hoping to learn more about vaccines and strategies to help improve vaccination within our country. Thank you.
Great. We'll have Abdul Jalal. followed by Nada, Simone, and Lauren. Lauren, so you guys can just go ahead.
Okay, thank you very much. My name is Abdul Jalal Nadabo. I'm from Nigeria. I'm a practicing pharmacist. I am currently a master's student in vaccinology and drug development at University of Siena, Italy. I am also currently an intern at Novartis, a global health medical intern at Novartis, India, where I'm learning mostly regulatory affairs. I'm here. My expectation is to have a good understanding of vaccinology through the African lens. I mean, in the past 6 months or more, we've learned a lot about vaccinology from a lot of professionals across Europe, the US, and all around the world. I want to understand better, not just the science. I mean, I want to see the challenges up close, the financing, the infrastructure, the regulatory gaps. Why is Africa where it is? Why can't we produce our own vaccine? I mean, there are a lot of questions that only a setting like this can answer. And I'm really excited to be here. Unfortunately, I had the chance to be here in person, but I couldn't be, and I had to ask Alana to make me for the remote version. Thank you very much.
You can go ahead, Nada.
Thank you. Good morning, everyone. My name is Nada Nair. I am from Sudan. I am a community medicine specialist, work as EPI consultant in Federal Ministry of Health, Sudan. I want to know more about how to overcome challenges of vaccine access and how to introduce new vaccine in a challenging context and conditions such as Sudan. And it is my pleasure to participate in this important course. Over. Thank you.
Good morning, everyone. My name is Simone Hendricks. I am from Johannesburg, South Africa, and I work as a medical monitor with a undergrad in medicine as a medical monitor for the HIV vaccine trial network. So we work on prevention studies in HIV, TB, and COVID vaccine. And what I'd love to learn is a bit to improve more on my immunology basics, as well as to see how, because I'm busy with the protocol development phases of early phase trials, how the rollout of or implementation studies can improve, and where I could work on with my team in terms of making protocols a bit more easier for implementation. All right, thank you so much. Okay.
Thanks, Simone. You can go ahead, Lauren.
Thank you. Good morning, everyone. I am Lauren Gilbert, and I am currently a Regulatory Affairs Officer at BioVac in Cape Town. Through this course, I'm hoping to strengthen my understanding of vaccinology a bit more and understand how we can improve immunization coverage and public health outcomes. Thank you.
Yep, that's it for.
Okay, it is wonderful to hear who's is going to be with us the next 5 days. We've had all the regions of the continent are represented, the central, east, west, north, south. We've got representation. And that is the kind of approach that this course focuses on, is to be inclusive. That's why it's an annual African. We try as much as possible to have representation from the whole continent. So with that, I think the other point I want to make was listening to your background and what you do. We've got an end-to-end representation of the vaccinology. We've had people who are involved in vaccine development from Afrogen and also BioVac. These are companies that are involved in vaccine manufacturing. we've heard about people involved in clinical trials, because once the vaccine is tested, shown to be safe and be able to induce immune responses, then the next is to take it to clinical trials. We've heard that some of you are involved in clinical trial testing. And then we've had some of you are involved in pharmacovigilance, which is quite important because the issue of vaccine safety is pertinent in terms of making sure that we give vaccines to our societies, and these vaccines need to have the confidence that they are safe. We've also heard about people involved in the immunization program in terms of programmatic role, making sure that the cold chain is working well, making sure that the vaccines get to the people that needs them. And we've also had somebody involved in the data. The issue of data in immunization is very important because it's helped us understand how our efforts are being translated into impact. And in absence of being able to collect data and see whether vaccine introduction, maturity of immunization program is resulting to reduction of prevalence and incidence of VPDs, it's not going to be possible for us to engage with the politicians and get the political buy-in of vaccination as a program, because we need investment, and this investment needs to be argued based on the data that we're able to generate. So the other thing that I think that came out from your introduction, which is very interesting, is pretty much every one of you is interested to learn, which is great. And despite me limiting you to 1 minute, I could see some people worked very hard to keep to even 3 minutes, let alone 1 minute. And that shows the passion of this team. And when we look at how successful these courses are based on the past, actually one of indicative thing that we look at is the level of engagement, right? So coming to learning, I have to emphasize this. You will learn certain much from the speakers that are going to be standing here presenting different topics on areas of the expertise. And they are world-class presenters, speakers that we've identified. But actually what we've realized in the past is another level of learning, which is equally important, is when you're having tea, when you're interacting with your colleagues from different countries, when you share experiences of all what you've learned in different areas of immunization that you're involved with. So when I see my brothers and sisters from Ethiopia sitting next to each other, I fully understand. That's what I do when I go with my colleagues from South Africa, you know, let's sit together. But try to interact, try to network. Networking is one of the objectives of this course, because we believe that the more we learn from each other, the more we can strengthen on what works, and the more we do not repeat on efforts to do what doesn't work, right? So experience sharing, learning from each other, it's a very essential component of this course. It may not be in the program, but it is actually something we deliberately and hope it's going to come through all along the period of this course. All right, so the other last thing that I'm going to mention is that we've seen the best way for this course to be of optimal benefit to you is if you keep time. So it was very impressive today that all of you, despite some of you dancing last night and staying late and being tired from all the traveling, you are here on time. That is very, very impressive. And actually, you should give yourself a round of applause for that. So you've set yourself standards that we're going to hold you accountable to for the rest of the program, the rest of the course, all right? So be on time, because when you're on time, then the speakers can start on time, and it make us able to stick to the program. Right. So with those few remarks, feel very, very welcome. We look forward not only for you to learn from the speakers, but also as the speakers, we want to learn from you. We want to hear your stories. We want to hear what works in your setting and what doesn't work. And we want to make sure that beyond this 5 day, of course, we can continue working together as a community of practice to advance and strengthen immunization program. So with those few remarks, I wish you the best for the next 5 days. Please engage, raise your hand, ask question, clarify, share whatever you feel could be beneficial to the rest. And as they always say, there is no stupid question. All right. So if I may ask, is there any of you who is vaccine hesitant? Exactly. Tell us why you're vaccine hesitant. No, I'm not going to put you on the spot. So please interact, ask questions, feel free to. We are now, we get to know each other, and let's get to know each other more over coffee. And for the next 5 days, let's make sure that when this course ends, it marks the beginning of the being included in the community of practice that we want to build for vaccines and immunization. And I will now hand over to Edina for the next session.
All right. Thank you very much for that, Ben. And thank you for all those in the room who took the time to introduce themselves. I'd also like to acknowledge the online group. I must tell you, it seems like the online is where it's happening. There's a lot of engagement and discussion. And as Ben mentioned, there's also the live broadcast on YouTube. And we have, broader stakeholders who are listening in. And they're introducing themselves to each other, posting their flags, and just seeing all that color reminds me why I'm so proud to be African. So good morning once again. My name is Edina Amponsa da Costa. I work with the Vaccines for Africa initiative as a research officer, an evidence-informed decision-making specialist. And as I mentioned, I'm also one of the co-conveners of the annual African Vaccinology course. So what I need to do this morning is basically to take us through the history of the annual African Vaccinology course, as well as share the core objectives for this year's course. If you were with us during last night's gala dinner, you most likely got a full course on the history and the legacy of the annual African Vaccinology course, but it's important to bring all the other compatriots on board. So there's this saying that I like to share year on year. Apparently, it's an African proverb. It's often affiliated with Maya Angelou, but it basically says, if you don't know where you come from, you cannot know where you're going. What it's trying to tell us is basically that without understanding our origin, it's difficult to set clear goals and make informed decisions about where we need to go and how we're going to get there, and even what we're going to do there. So what I need to do this morning is for us to agree on what we want to achieve from these next 5 days. But we can't agree on that until we understand why we are here. And so that is what I'm going to try to do this morning. So every now and then I hear some participants, some alumni, even some faculty members say, oh, I attended VACFA. And then there are others who say, I attended the AAVC. So which one is it? Let's set the record straight. So just to say you are attending the annual African Vaccinology course, you are attending the AAVC. But who is VACFA? So the Vaccines for Africa Initiative, VACFA, is a research and academic unit that is based at the University of Cape Town, based within the School of Public Health or the Department of Public Health. We are not only a group of very good-looking, very talented individuals. You saw Tony with the guitar yesterday, and I tell you, it gets better. Well, wait till you hear Prof. Benjamin rap. But our vision is basically to see an Africa free of vaccine-preventable diseases. And the fact that you are in this room, the fact that you are online, the fact that you are listening in via YouTube tells me that we have a shared vision, correct? Okay. In terms of our vision, our mission is to increase awareness of the benefits of vaccines and to promote the uptake of established and newly available vaccines in Africa. And then now, what is the annual African Vaccinology course? Probably one of the best vaccinology courses on the continent. You heard very much yesterday that we are the forefront of vaccinology capacity development in Africa. And our purpose is to build vaccinology expertise for Africa. And now, as we move into the next 20 years, we understand that it's not just about technical knowledge, it's also about cultivating vaccine champions for Africa. And that is, it is so important now more than ever. So we're celebrating 20 years of the annual African Vaccinology course. The first course was back in 2005. And this course was basically set up on the premise of trying to promote vaccine advocacy among healthcare professionals, among public health managers, policymakers, scientists, and all other stakeholders who are working across the immunization landscape. So basically, all of us gathered over the course of the next 5 days. Does this look familiar to anyone at all? Okay, oh, it seems like I'm triggering people. That's good. Where did you see this? LinkedIn, okay. Everybody LinkedIn? Where else? Your sister. So it's a family. Okay, so your sister attended the 16th AAVC and she shared the flyer with you. Okay, please tell your sister we said hello and we thank her. So it's good to see generations. Anywhere else apart from LinkedIn, online, family members? Colleagues, very important. Because I'm going to touch on, the alumni, very, very important. These are ambassadors of our course, and they do an excellent job, just basically sharing the course or the opportunity to apply with other colleagues. So every year we open up the call for applications. I can't remember when we did this, Alana. Was it in July? In August. So we opened it in August. It was for about 3 weeks, 3-4 weeks. And we had, a lot of applications and we'll come to that. But the idea is to open up the opportunity for as many interested parties as possible to apply for the course. So Ben had asked if there were any repeat offenders in the room, and it seems like everybody is indeed attending for the first time. Yes. Anybody attending for the second time? No, okay. Anyone that has applied more than once? More than once, okay. I'm glad you are finally here. It's a tough road. Thank you for your persistence. We truly, truly appreciate it. And we'll come to the challenges of trying to create access to this course. All right. So this image here is very important. What you're seeing here is basically a graph that shows the number of applications we receive every year, at least in the past, I don't know, since 2011. And I think it's very obvious. The story is very telling. In this year alone, we almost received 700 applications. So you're not here by chance. If you're online, you're not there by chance either. It's a highly competitive course. And it seems like the more we train, the more applications we receive. So at least we keep having a job every year. That's one thing. But it's very positive for us because it shows that the popularity of the course is growing. It does give us a lot of work because it means that the selection committee has to screen through almost 700 highly deserving applications in order to find the right group of individuals. And sometimes we actually, not sometimes, we get a lot of hate for it. You can ask Alana, she's healing. Because we sometimes get a comment or an email from someone who didn't make it and they say, I don't understand why I didn't make it. I have 15 years of immunization experience and I deserve to be there more than anybody else. It's probably true, but it's not just about experience. It's about the diversity. If you listen to the introductions, we don't just have immunization program managers in the room. We don't just have professors. We don't just have postgraduate students. We don't just have policymakers. We need the right mix. This course only works when we have the right mix of individuals. And the diversity and representation is also important. So we are only able to support one representative from each African country every year, which is why you probably can't find a compatriot in the room. But the good news is you have a compatriot online. Of course, some countries are a lot bigger. I said we received around close to 700. We received over 100 from Nigeria alone, about 70 something from Ethiopia alone, Kenya as well. So you can just imagine the number of individuals that we have to support to come in here and be in the room or either be online. So this is the one story. We now need to look at our footprint as the annual African Vaccinology course. So as I mentioned, we started back in 2005. In the first 5 years of the course, we had already reached 33 countries and trained 420 individuals. The other thing that I should mention about why we select the numbers that we do is if you're in the room, you can tell that there's no way we can sit 700 people in here. It would be illegal. We will go to jail. Aside from that, it's important that we keep it intimate because we want that level of direct engagement with each person. So sometimes the numbers don't matter too much to us. I mean, maybe in the past 20 years, we could have trained, I don't know, 50,000 people. But every year, it's important that we keep it intimate to allow that direct interaction. So moving on, 10 years later, we had reached 42 countries and trained 713 participants. Fast forward to 15 years, we had reached 46 countries and trained just close to 1,000 participants. And by the end of this year, with all of you in the room and online, we have reached 49 countries. And by Friday, we would have trained 1,223 participants, which I think deserves a massive round of applause. Now, the reach is very important to us. You can see where the little gaps are. I don't know if anybody has a direct line to Libya, but you need to contact them. And Inez, okay, Inez, please call Libya and tell them we're missing them. Last year, we had our very first participant from Morocco. And as I said, the ambassadors are important because she did a fantastic job making sure that she spread the news. And we have another participant from Morocco this year, and you're welcome. We hadn't had a participant from Djibouti ever. And then this year, Mr. Tony. So we're making inroads, which is good. Your job doesn't end here, either in person or online. It's also about being a strong ambassador for for the course, not just so we can have people sit in the room, but so that we can continue to build vaccine champions all across Africa. Another favorite slide of mine is to show the diversity of the course. And I was sharing this with the organizing team. I think 2 years ago, we probably had about, I don't know, maybe 10 or so countries represented. Last year, we had 29. This year, we have 40 African countries represented both in person and online. So as I mentioned, of the close to 700 applications that we received, we were able to basically refine it to 97 applicants. And of those, 63 are in person, and we have another 34 online. And I will tell you that the online participants were actually ready to go before you were. So the competition is tight. So you need to keep up, or else we're going to switch it. As Ben said, it doesn't cost us too much to immediately change your flights and switch the in-person. So we have a diverse group of individuals. We have people from expanded program on immunization, from country officers. We have healthcare providers from both public and private sectors. We have representation from national immunization technical advisory groups. We have from ZITAG. And I think there's also a representative from the Botswana NITAG, if I heard correctly. Yes. And we have academic researchers, postdocs, postgraduate students, immunization program partners, as well as non-governmental organizations, representation from the pharmaceutical industry, and many, many others. So I need to touch on how we go about addressing this gap in terms of how many applications we receive and how many we're actually able to train year on year. Naturally, as you saw, the overwhelming demand for the course far outstrips our ability to actually train. But we have been very dedicated to finding a way that we can make sure that we can train as many as apply. So one of the ways that we've gone about this is to switch to a hybrid format. And in fact, it wasn't necessarily our desire. COVID forced us to look beyond just in-person representation and add on online participation. And every year we try to improve this hybrid format. The online participation is incredibly important to us because we know that it's very hard to take time off work for a week to sit close to your laptop and try to dedicate time. Sometimes you can't actually get that time off and you need to be doing multiple things all at the same time. So we've been trying to modify it year on year. I don't know that we have it to a perfect science, but this year is our 5th hybrid format. We created 45 slots for those online and 34 registered. As I mentioned, the selection criteria for the in-person participants was just as stringent as that for the online participation. And our participants online will also be receiving certificates at the end of this course. However, there is a defined strict criteria. So if my online colleagues are listening to me, you need to be engaged throughout all 5 days, and we will know if you just had the Zoom on and you were somewhere else. I won't tell you how, but we will know. I'm a retired ninja. Aside from that, we want to see rich engagement, discussions. We're doing our best to make sure that we can switch between the room and online to have questions and suggestions. So please bear with us as we get through the rest of the week. It's important for me to acknowledge our AAVC faculty. Just as much as the participation is integral, the right kind of faculty the type of faculty can make it or break this course. And we are so fortunate over the past 20 years to have a rich representation of faculty members. You will see from this map that the majority are in fact from the African region. And even those that are not are very, very well embedded within the African context, and so can ensure that everything we're going to be discussed will be aligned to our local needs, but also aligned to global discourse. So we've had representation from universities, from immunization partners. We've had representation from the WHO, from UNICEF, from the pharmaceutical industry. By and large, the majority of our faculty comes from South Africa for some obvious reasons, because we don't have to fly them in, but also because we have rich expertise in here. But I can assure you that the various faculty members that you'll be hearing from are basically going to blow you away. So please keep engaged. So now to the objectives of the 20th Annual African Vaccinology course. I need us to focus here because this is something that we need to agree on. We're going to come back to these objectives towards the end of the course, and we're going to assess whether we've been able to meet these learning objectives. So the very first one is that through the AAVC, we would like to provide you with essential and up-to-date knowledge on vaccines. Would like to create an environment that fosters dialogue about the successes, the challenges, and opportunities to improve national immunization programs in Africa. The idea is to provide you with a forum for sharing immunization policy-making experiences and to develop technical capacity. And lastly, we want to foster communication and networking among African vaccinologists. And as Ben said, you need to leverage the time we spend together, the time during tea time, and even for the online participants to really try their best to engage with each other. And we are trying to find ways to create a community using online or social media spaces where both in-person and online guys can also engage. So please self-assess or assess the course as we go on over the next 5 days, and let us know, shout if we are not meeting any of these objectives, because I think these align with some of the things that you said you wanted to achieve during your introduction. So I'm showing this picture because aside from being very proud to be an African, I'm incredibly proud to be working with the Vaccines for Africa initiative. This is not the full group, but this is one of our best pictures. And we're not pretending, we're incredibly happy people. I'm glad that you all said you want to learn about vaccinology and how to improve immunization systems. I was a little sad that no one said, I want to have at least one best friend from VACFA. So I'm putting this picture up because during the course of this week, you need to connect with at least one VACFA member. It will change your life. It has changed mine. So take the opportunity to get to know us. Let's have a chat, let's discuss, and let's see what opportunities are available to continue to collaborate and engage. Lastly, I have to thank our partners and sponsors. We work very hard throughout the course of this year, but this course will not happen if our sponsors, our partners, our donors didn't contribute to ensuring that we are able to organize and fund this course. I don't know of many other African vaccinology courses that does its best to fully fund as many participants as possible to come here. The idea is we want to do away with the financial burden of accessing vaccinology training. And I must say that over the past 20 years, we have been incredibly successful because of our various partners and sponsors. And so a massive thanks to the University of Cape Town, Sanofi, CEPI, BioVac, MSD, Afrigen, the South African Medical Research Council, and the NITAG Support Hub for their support in ensuring that we're able to have this 20th Annual African Vaccinology course. And so with that, I'll stop here and I'll check if there are any questions from the room or online. But if not, massive welcome. I think that you're going to enjoy this course. And if you don't, I will give you a refund. But I can assure you that you will. My last statement is basically that every year I've been accused of saying that the cohort of that current year is the best cohort that we've ever had. But I realized that I was basing it on first impressions. And so you will not fool me this year. I will wait until maybe Wednesday. But based on last night and this morning, I suspect that we're going to have a fantastic time together. And so I'm looking forward to spending the next 5 days with the best AAVC cohort we have ever had.
Thank you so much, Edina. So we have done exceptionally well with time. We have 9 more minutes before coffee break. We can either go for coffee break now. That was such a big yes. Okay. We listen. All right, we listen to what you say because we believe it's by listening to you we're going to have the best course, correct? All right, so let's go for coffee and come back at 10:30. For the time that we've created for now, please, I encourage you, get to know your colleagues. Those connections will be so valuable when you go back. It is the connections that happens over coffee. You know, sometimes it could be talking about let's go for a walk, and that leads to other thing. I've heard about some big grand ideas coming up over coffee. As you have your coffee, tea, whatever you call it, make sure you have some discussion ideas that are going to be quite instrumental in addressing some of the challenges we face on the continent related to vaccines and immunization. So thank you so much and see you at 10:30. Giving us the
I'm not trying to help. Thank you for your time. And I don't do that. Oh, that's very funny. Yeah. Yeah. No, it's a. The people celebrate. I had to. But so no, I think better. Yes, it's like
No, not yet. They about. Yes. Oh, yeah. That's all. Okay, that's all. That's all. Yeah, yeah.
Oh, yeah.
Yeah.
But does it advance the slide?
It does this one.
Okay. But I think I'm going to go second.
Yes. I think Mohammed Farid is going to present first. Okay, you can test it from this.
So if I click.
Is it on?
Does it,
maybe
no, I'll use this. It's easier.
Maybe it just
Huh?
it just needs to be in presentation mode.
Probably.
Enough, right?
Can you put it in full presentation mode?
You want to
in full presentation mode.
For you also.
For me, yeah, full presentation. Oops.
Okay.
No, it doesn't work. Anyway, don't worry. I'm not going to. Is this the
laser pointer.
but the laser? But it's probably easier
using this. I'll set it up so that when you come in,
can't you
it
put,
will make it
can't you make that like a red thing? Yeah. You remember that? You can actually see it.
So that
Oh, that's better.
When you move.
Yeah.
Good morning. Can you hear me?
Yes, we can get you.
Can hear you.
Yeah, thank you.
Yes, we
Yeah,
can hear you.
thank you for confirming. Let me upload my slides. Yeah, my slides are now visible.
Yes.
Okay, so we'll wait for participants to come and then we can start. Thank you.
You not presenting now, no?
No, it's after, but it's this
No,
one.
no, not.
Not this one.
Yeah.
Second one. That's
Okay.
second one.
Mohammed, can you hear us?
Yes, I can hear you.
Mohammed, can you hear us?
Yes, I can hear you.
Okay,
Can you
awesome.
hear
Thank
me?
you. I was just testing. Are we just finishing up our break? Maybe give us 5-10 minutes and then you
No
on.
problem. Let me know once participants are back.
Okay.
Thank you.
So be online.
Yeah. So,
So this is it's like,
yes, that will be to move the slide. So when you come up, I will make sure that yours are loaded already.
Okay.
And then you will just come up and
that point.
this the keys are ready to, but we're going to add the thing, you know, on the PowerPoint where you move this around and what.
Oh, you can.
The thing, yeah.
Early in the morning, it's like it's all right. Having it early. I think these two. Okay, good. Go give you some time. Yes. Yes. Yeah, I used to talk to you. Yeah, I do. I enjoy this. I think this one is, I like. Yeah, this is, it gives the reaction. Yeah. So happy. I'll do that. Yeah, that's good. Yeah, actually.
Hello. Can you settle in, settle down? So we are on time, like we were in the morning. If someone can call the people that are still outside for me, please. Thank you. Okay. So we've had welcoming remarks from Ben and Adina this morning. So I want to say we are officially kickstarting vaccinology now in this session. So there has been, I know you have programs in front of you, there has been a few changes. Instead of starting with Greg for this session, we'll start with Muhammad Farid, who was initially supposed to present at 2. So we'll have Farid and then Greg, and then we'll have Nekaise and Demi, and then Jason will go into Muhammad Farid's spot in the afternoon. So let's just get into it. Farid, can you just confirm that you can hear me?
Good morning. Yeah,
Yeah.
I can hear you. Yeah.
Okay,
I
great.
hope I'm audible.
Yeah, I think you are.
Thank you.
Yeah. Okay. So we'll have Dr. Mohammed Farid from WHO. He's currently based in Egypt. Give us a talk on immunization during crises, navigating humanitarian conflict and climate change. I think if you were listening intently yesterday to Greg's talk, he did mention that we've had a few crises. One of the long-standing crises we've had is the civil conflict in Sudan. And now recently, we're also seeing what's happening in Gaza, and there's also Congo and many parts of the world. So this is a very important talk. So listen attentively, and let's have an engaging discussion or question and answer later on. Dr. Farid, you can go ahead.
Thank you so much. Dear all, good morning. And thank you for the flexibility. I'm traveling at the same time of my previous ISPER agenda, my session. So thank you for giving this opportunity and flexibility. Let's start with the crisis. It is seems like part of everyone's life, and also globally it's happening. Somewhere, sometime, like it's a continuous process, seems like it's a usual now, a normal or a new normal for us. A few years back, I was sitting with Ben and we were discussing, I just say there's a chronic emergencies in one of the country in Africa. So the chronic emergencies seems like it's never ending. So let's go to the definition of what we mean by emergency. Let me try to move my slides. Yeah. So it's a definition for a health emergency is the WHO. It's considered an event that has the potential to cause ill health on a scale that exceeds the ability of community or country to cope using its own resources and require external assistance. So there is also a definition, almost same, but just another version. Any event or condition that poses an immediate risk to health, life, property, or environment on a large scale, including disease outbreaks, natural disasters, conflicts, or other crises that demands a timely and a coordinated response. Let's have a look what is happening in Eastern Mediterranean region of WHO. So in Eastern Mediterranean region, there are countries from Asia, countries from high-income countries like Gulf countries, and also countries from Africa. I was listening to Edna's speech, and she was saying that we don't have anyone from Libya, so I will communicate with Libya team, and hopefully soon, next year, we will have participants from Libya as well. So looking at the emergency in Eastern Mediterranean region, 115 million need assistance. It's the third largest displacement crisis in this region. 46% of global IDPs hosted by countries in Eastern Mediterranean regions. 57% of global refugees originated from region of these countries of this region. And 15 graded emergencies of level 3. Out of 15, 8 were of level 3. And 56 disease outbreak happened in 2025. So how these emergencies are impacting routine immunization? Prolonged conflicts that led to the destruction of health infrastructure, making it difficult to maintain routine immunization services. So destruction of health infrastructure. Then healthcare workers have also displaced because of prolonged conflict, are unable to work due to safety concerns. Population displacement is another significant challenge. And then natural disasters have disrupted vaccination by damaging cold chain equipment and making it difficult to transport vaccine to affected areas. COVID-19 lockdown and movement restriction have hindered access to vaccination services, leading to declines in vaccination coverage and increasing the risk of outbreak of vaccine preventable diseases. Because of this situation, the resources and attention also moved away from routine immunization to other immediate emergency response efforts. So combining all those disasters are impacting heavily, negatively, routine immunization. Looking at situation of Sudan, because of recent issues in Gaza, in Sudan, 20 million population in need of health assistance, and 12.4 million people forcibly displaced. 11 out of 18 states experienced at least 5 outbreaks. And more than 21 million population are in the food insecurity. and famine condition in Al-Fashir. Gaza is also, everyone is aware of Gaza's situation, so they are also facing issues in Gaza. Let's check Somali situation, which was a very badly impacted by different emergency situations. This slide is just a snapshot of that emergencies in 2023. Around 50% population were affected by this famine and drought situation. In one of the document of WHO, it is titled, Responding to the Drought in Somalia, stated that the extreme and catastrophic level of hunger and acute malnutrition provided ideal ground for disease to thrive among children. MOH with WHO and partners averted a major health crisis by rapidly mounting immunization campaigns that averted large-scale epidemics and possibly any significantly high excess deaths, which was the most fearsome consequences of an impending famine. This slide is from polio program, GPI, but the purpose of this slide to show it here, just look at the CVDPV cases. There are two countries in Eastern Mediterranean region, Afghanistan and Pakistan are endemic, but CVDPV cases are all around the African region as well, other countries, even including Bahrain. So these diseases can go to any country, not respecting their borders. I will mention again Somalia, Sudan, Egypt, and also Djibouti. So they are having either cases from human or from environmental samples. So let's see what is happening from the lenses of statistics and data. So this slide is showing global estimates of DPT1 and DPT3. In 2024, DPT1 coverage remained constant at 89%. The number of children missing out on any vaccination, we call it zero-dose children, increased from 12.9 million in 2019 to 14.3 million in 2024. DTP3 coverage remained constant at 85% in 2024, leaving around 20 million children vulnerable to vaccine-preventable diseases. There are 171,000 fewer zero-dose children and 426,000 fewer under-vaccinated children in 2024 compared to 2023. So some improvement we are seeing in 2024 compared to 2023 at global level. This slide is showing what is happening in different regions, especially of WHO different regions. So in 2024, American and CRO are performing better than in 2019 for DPT3 coverage, while African region has fully recovered to that level. So African region is performing better in recovering to the level of 2019. But in Eastern Mediterranean region has lost grounds because of conflicts in Sudan and Yemen. So not very good news for Eastern Mediterranean region. For DPT3 global level, the number of children vaccinated with DPT3 decreased 8% from 116.6 million in 2019 to 109 million in 2024. Again, a good news is immunization program. In 2024, 7 million children, fewer children were vaccinated than in 2019. MCV1 and MCV2 coverage are very important, and from the lenses of immunization each under 2030, it's a proxy indicators for immunization coverages. So if MCU1 coverage is low, it means like something is wrong with that community or that area. And we also call it like tracer for protection, MCU1. The percentage of children received MCU1, they are more typically at 9 or 12 months, depending on country schedule, remain at 84% in 2024, and it is lower than in 86, which was in 2019. 20.6 million children missed their routine first dose of measles vaccine. MCV2 coverage remained at 76% in 2024. So let's see which are the countries, the top 10 countries with the most unvaccinated children and lowest MCU1 coverage in 2024. So it's Nigeria, 3.1 million, Democratic Republic of Congo, 1.9 million, Ethiopia, 1.1 million, Pakistan, 926,000, Sudan, 870,000. So these are the countries with the lowest MCU1 coverage and also with a high number of unvaccinated children. And then let's see countries with lowest MCU1 coverage globally. So first one is Montenegro, which is at 23%, Yemen 41%, Central African Republic 41%, followed by Benin, Papua New Guinea, Sudan, Madagascar, Angola, and the Democratic Republic of the Congo at 55%. So this is bringing back to AMRO region. This is Eastern Mediterranean region in 2024. DPT1 coverage remained relatively constant within 1% at 85%. And then DPT3 coverage remained relatively constant again within 1% at 79%. So somehow it is dropping from 2023 to 2024. It's a 1% drop in both antigens. Here we have top 10 countries with the most zero-dose children in Eastern Mediterranean region, starting with Sudan, 838, Yemen, Afghanistan, Pakistan, Somalia, Syria, Iraq, Egypt, Iran, and Saudi Arabia. The green circle are showing different coverages, improved coverages like more than 95%, 90 to 94%, while red are the least countries with least coverage, less than 50%. But there are also good examples from countries which perform better, are trying to improve their coverage compared to 2019, like Djibouti, Egypt, Libya, Somalia, and Syria. Compared to 2019, their program is struggling to improve, and they are successful in that. MCU1 and MCU2 coverage in Eastern Mediterranean region, it's 80% for MCU1 in 2024 and 75% for MCU2. Dropout numbers declined significantly from 5.8 million in 2000 to 0.8 million in 2024. So if we look back at the program, so there is an improvement of improve dropout rate, in numbers from 5.8 million to 0.8 million. So that is somehow we can be proud of as a program. Here we are seeing countries with zero dose for MCU1, majority like top countries in Eastern Mediterranean region, starting from Pakistan, Sudan, Yemen, Afghanistan. In Pakistan, coverage is around between 80 to 89%, while coverage in Sudan, Yemen, and Afghanistan, they are less than 60%. Again, unique estimate showing country-wise coverages for MC1, and we are seeing like there is some improvement compared to 2019 in same countries, Somalia, Djibouti, Egypt, and Libya. So let's see the good work of countries in crisis. First example is coming from Sudan. They introduced rubella containing vaccine recently. Their target population is around 20 million, 37% from 9 months to 15 years. So far, 11 states out of 18 implemented catch-up campaign, and 8.6 million children received vaccination during catch-up campaign. Still, they are looking for any available window, and they are providing their vaccination. And vaccination is also serving as a gateway to other health services. This is an example from Somalia country. Somalia team, immunization team, and all health team are struggling during this time from in era of COVID-19. And you can see from the slide, by end of 2022, the country was able to fully vaccinate more than 41.7% of population. So that was achieved because of, I will come to that, how they achieved this one. But one most critical key point was a teamwork of everyone involved in immunization program with flexibility. So this is one example. So as a lesson learned from that experience, planning needs to be local, very local. Immunization program is a program which needs to be implemented at community level. So, and when it comes to polio program, so it is inside the household. So that key activity needs to be done at very local level planning and also implementation. And use window opportunity for accelerated campaign by engaging local authorities. Federal and state ministry led the campaign with UNICEF and WHO support in Somalia. The highest position of UN in Somalia was Deputy SRSG and a humanitarian coordinator. They were involved in this campaign, accelerated campaign of COVID-19, and we were also, the team was also integrating it with routine immunization. So that is the highest level of engagement from donors, and Minister and Prime Minister office was engaged in this campaign for political reason and also for oversight. Gavi and other donors allocated required financial resources. So they were very listening to the team in the country, and they were providing all support required. WHO, UNICEF regional office, COVID-19 partners, and including COVAX, they provided vaccine. J&J vaccine was in demand, so they provided J&J vaccine to the country. Then the other important activity was vulnerable population and identification in each district. So local teams were identifying those vulnerable population. Microplan developed a bottom-up approach, and then 4.5 million doses of J&J vaccine and the logistic distributed. During this accelerated campaign, more than 37,000 HR was engaged in all states. Additional monitors were deployed, and campaign was implemented in staggered manner, so showing flexibility for the implementation. In addition to routine vaccination, there was also other services were added to it. So, like children receiving deworming tablets, and also ORS and zinc, and pregnant women have been protected with 2 doses of tetanus and diphtheria vaccine. So additional services as per the need of that local contacts were added. And at that point, some of the inaccessible areas are security compromised areas were also reached through local engagement of elders. And that was a gateway for provision of health services, like immunization was playing is a bridge between that community, building trust, sending teams are training the local team over there, and then providing logistic and getting what was supposed to be done. So it was also, again, a good lesson learned from that experience. During that crisis, Somalia team was able to change it to is opportunity for them, and they built their health system or contributed to improved health system. SDDs procured for health facilities and establishing district vaccine stores at that time, and then walking cold rooms procured, expanded national and state store capacity. Strengthening of vaccine supply chain, many people were trained and different approaches were adopted. Some what they call passive containers were also procured, which can sustain temperature up to 28 days without any power supply. So all those things were happening simultaneously during that time. So the most important is streamlining of the communication and coordination among the stakeholders. Again, it is also related to trust and also to the local contacts. Local community engagement and all involved in provision of health services. Ownership and commitment at state, regional, and district level was very visible by ministries. Then target population were identified by community health workers. I already mentioned about flexibility and regular feedback to implementers, vaccination teams. Integration of services have better outcome. It led to build country capacity in management and oversight, expand the cold chain storage capacity, and continue to build capacity on vaccine management, generate demand for vaccines, target the vulnerable population, and improve and modify recording and reporting tool, and support in improving the fragile health structure to deliver in time of emergency and provision of PHC. So let's see is a snapshot of Somalia performance. It's a case study for a country struggling in emergency, and they proved that it can be done. And this is a unique estimates of last year, released in 2024. Let's see what has happened. In 2017, DPT1 coverage was 59%, and it was stagnant for quite some time, maybe 6, 7, or 8 years. During that time, and we can see an improvement in 2019 when there was a COVID-19 pandemic. It has improved to 78% in 2024. DPT3, which was 51% in 2017, has improved to 70% in 2024. It's a journey. It's a story of a country success during these crises. And MCU1, it was 52% in 2017, which has improved to 64%. Not only campaigns are accelerated campaigns Somalia implemented, but Somalia also introduced a new vaccine during that time, that was IPV2 and MCV2. And recently, in 2024, 2025, early 2025, they introduced Rota and PCV, but they submitted application during 2023 or 2024. They also implemented integrated campaign. The good point was for data management, they introduced electronic immunization registry for COVID-19 and then replicated for routine immunization in one state they piloted with the objective that they will expand. And cold chain capacity, managerial capacity, everything has improved. So I will stop here. This is my last slide, and we'll be happy to respond to any question.
Thank you for a brilliant presentation, Dr. Farid. I would just like to say that there's a comment online that says your slides were perfect. So, any questions in the room for Dr. Farid?
Hello, my name is Omnia. I'm from Morocco. Thank you, Dr. Farid, for the wonderful presentation. My question is regarding how to keep track of the target population in a context where there's a lot of mobility to avoid under purchasing or over purchasing, especially in a context where resources are diverted away from routine immunization. Thank you.
You can respond, Dr. Farid.
Okay, yeah. So thank you. Yeah, this is a challenge in countries, especially when it comes to population movement. The key intervention is engagement of healthcare workers, local healthcare workers, or community health workers. So because in Somalia, they deployed community health workers for COVID-19 vaccine, COVID-19 surveillance. And in addition to COVID-19 surveillance, country also asked them to track children for routine immunization and also for COVID-19 vaccination when it was introduced. So it was a challenge and it will remain a challenge, but somehow at that point, community health workers were a key for monitoring those targets.
We are missing a mic. Can someone just check? Everyone just check. Oh, there we go. Thank you.
Thank you, Dr. Farid. My name is Olayinka Badmus from Nigeria. So which immunization data is accepted as, global? Is it DPT1, DPT3, MC? Again, the vaccination coverage that is used to measure most countries and why? And why do we see a higher uptake in DPT1 compared to DPT3? Is there any lessons that we've seen? The reason why, again, we don't have similar coverage for both immunization. Thank you.
Yeah, thank you. Let me respond to your question. In fact, there are so many data sources like administrative coverage, which normally is very high compared to reality. And then we prefer is immunization program, UNIC estimates, that is WHO UNICEF estimates. They released every year for all countries, regions. So that is normally considered to be a close to reality. And then UNIC estimate is estimated based on admin coverage, local contacts, surveys, campaigns, everything it's a statistical method. So beyond of my knowledge, but that is the preferred one, which is considered to be a close to reality. When it comes to why it is higher DPT1 to DPT3 and going back to up to measles vaccination, there are multiple factors, especially if I talk about the crisis countries. So the basic instinct, it's about survival. So no one will think of vaccination if they don't have food, or if their life is at risk. DPT1 is a first contact with vaccinators. So one of the maybe one of the reason for lower DPT3 is our behaviors of vaccinators or healthcare workers. Maybe we are not briefing them properly, the parents, and they are not consider vaccination is a priority. This is one sign. And then also from the other side, low demand for vaccines, low risk perception. So multiple factors are engaged. But in contexts like in emergencies, it is more relevant, the briefing of vaccinator to the parents that it can prevent your children from different diseases. So then you need to explain their economical or financial implication as well.
Thank
I
you.
hope I answered your question.
Right. Yeah. Is your question answered? Yeah. Yes, we're happy. I'll ask 2 questions online and then we'll continue with the floor. We do have enough time for all the questions today. So there was a question, Dr. Farid. They're saying that you showed when you're showing the, where the zero dose cases are, there was Sudan. So someone wants to know whether that's South Sudan or ancient Sudan.
No, I was showing slides. My slide was showing Sudan, not South Sudan.
Okay. Okay. Thanks for that clarification. Tapiwa Ntwere, you can unmute and ask your question.
Hi. I think my question was already asked by the previous presenter, so
Okay.
it's already been responded.
Okay, great. Thank you.
Okay, thank you very much, Dr. Mohamed, for that wonderful presentation. I think you have taken us through the trend in terms of immunization coverages, particularly in areas that are experiencing emergencies, more so Somalia. But at some point, you have highlighted that it has been a drastic improvement compared in the previous years and to the recent. What were some of the best practices that have been put in place that lead to that impact? Can you highlight some of the best practices so that we can learn from those things? I know, by the way, I'm Lamin from the Gambia. Thank you.
Thank you, Lamin. In fact, yeah. Meanwhile, yeah, let me respond to your question. In fact, I highlighted few of the key interventions, starting from high-level engagement at political level from ministry and also UN, and then bringing in donors. Also, our regional offices played, I mean, UNICEF and WHO regional offices also were engaged. So that is like engagement. Then local planning and, dedication of a team. When it comes to political engagement or political will, the country was showing really when it came to technical level, not ministerial level. Minister was engaged, but the DGs and directors, especially director of immunization and public health, they were very much engaged. So that was again community up to the community engagement. And then from the other side, like Somalia introduced electronic tool for data management. It was first time that country has introduced, and it was replicated for routine immunization so that is from data management. And then community health workers. So it is a holistic picture. You need to see it. Community health workers are community leaders. So they were also engaged at local level. Vaccinators were recruited or engaged from a local community. So, there was no barrier from that perspective as well. So they were easily accessible. So there are multiple factors I highlighted in my slides. So it's there. So hopefully you will review, and in case you have any question, you can reach out to me.
Hi, thank you for the presentation.
Thank you. Okay, I want to thank you, Dr. Farid, for your insightful explanation. I have a question. I think if we adopting a proactive approach to strengthen immunization preparedness, how we can adapt this approach, this proactive approach, and to respond to health emergency, particularly through strategic vaccine availability, strategic vaccine manufacturing, and supply chain resilience. There is example for country and there is example for proactive plan have taken in this site. And thank you.
Yeah, thank you. I think you are referring to preparedness in emergencies. Our proactive approach in emergencies. Yeah, so one point needs to be clarified. Is it preparedness you're talking about, or proactive approach during emergencies? Sorry, I was not clear. So.
Yes, I need to clarifying. This is more. We need to take more proactive approach to preparedness for emergency before emergency or
Yeah.
crisis happen. As emergency and crisis happen in unexpected, and in one night everything's changed. So I
Yes.
think from to take emergency preparedness, it's a strategic direction. I need to prepare for emergency before it's happen. So
Yes.
I need the approach or examples for country who take it this approach.
Yeah, thank
Thank
you.
you.
So different countries are developing their preparedness plan based on their local circumstances and what type of emergency they are considering that it can hit them. But coming back to immunization program, in each program, like from health perspective, we need to consider immunization program is a component of PHC. So by that, it can be improved. When it comes to resilient cold chain or immunization supply chain, so again, depending on crisis which country will face, so that needs to be considered. So there is not like 2+2 example from any country. It depends on local contracts, country by country, it varies. But the whole holistic picture is like that immunization program needs to be considered is a PHC component, an integral part of PHC for any plan.
Okay, this is Sherifat from Benin. So I know you mentioned using community health workers, but I'm thinking, I see here an opportunity to leverage the experience from the crisis context to reach zero dose children. So I would like to know, what would you recommend as a strategy using the experience from the crisis context to reach more zero dose children and under-vaccinated children in our countries?
Thank you. Yeah, this is very important, especially zero dose children. In these crisis countries, our countries in emergencies, it's always a challenge because there's a population movement always. So one is if we have good data system and reliable data sources, which is again a challenge. So it will be very difficult to identify from upper level. So my suggestion is that for immunization program, we need to go down up to the health facility or community level. And again, community health workers is one component of community engagement. It's not the only source. So you can think of which type of intervention or community engagement will be better in the local contexts. Maybe community health worker is not very trusted amongst the others. Like there's a traditional healers, there's a non-skilled workers, which are considered by community a very like type of respectable and trusted one. Sometimes it's doctors, sometimes it's religious leaders. So it depends. But from the data perspective, it will be good to look at the data also, whatever data is available, because data cannot be a perfect. And then surveillance data is also very much important. If we are getting cases from some community, so it shows immunity gap. So then team can go and look at it, which community and who are vaccinated are very through a very quick assessment of like 30 household survey or any other format which is applicable and doable in that context. Over.
Thank you, Dr. Farid. So we'll take 2 questions online and then one last question from the floor. So the first question online is on Somalia's success. So Colette is asking, are these improvements in Somalia due to greater stability or joint efforts? And then she's also asking, are there any documents that describe in detail the strategies that have been implemented?
In fact, it was a team struggle. I will say at that time, like crisis brought everyone together. So team struggle, joint team, one vision, one team. That concept was a key to success. There are few publication on this success, so that can be shared from WHO and also from ministry. Publication were made by WHO and also from ministry.
Thank you, Doc. There is another question from Kone. They're asking what are some of the reasons Saudi Arabia is among the top countries with the highest number of zero-dose children?
So they are not vaccinating children. So they are not reaching because, in this type, like those countries, they have very good health system, but somehow people not coming to avail those services. So that is the main reason.
Yeah. One last question from the floor on our left.
Thank you, Dr. Farid. I'm just curious. Mine is on the record since we are talking about the crisis area. Are we able to find these records, immunization records for your children? I'm asking, I just wanted to find out if we're targeting the same children, like to be able to identify to say this child is actually fully immunized. They've received all the doses required by them. Something I would like to learn. Thank you.
Yeah, that is a challenge, especially in this type of situation, because card retention is very low, and then it is only information is historical or memory of parents. So that is a challenge. And as I mentioned, that country piloted electronic immunization registry in one of the state. It was Banadir, I think. So hopefully that will somehow improve, but it will remain a challenge. And again, in this in this type of situation, I think if a child receives repeated doses, so it is beneficial to the child because measles is still endemic and children cases are coming every year. The outbreaks of measles are continuing in these countries. And measles is a stressor for immunity gaps. So, yeah, I can respond. As of now, this is the answer.
Okay. We have one bonus question because
Okay.
we did really well with time. One last question.
Thank you. My name is Delish Nyanombe. I'm from Mozambique. Congratulations for the presentation, Prof. I would like to ask a question related with humanitarian crisis in the context of the presentation you did. You know that the question is how do you determine the appropriate use and avoid the wastage ratio in a country that is facing this crisis for long years? The reason why asking this is how do you, considering the target allocation, considering that the target allocation is normally used or based into national institute data and other sources. In this case, could you share with us the experience of Somalia, for example, in order to avoid wastage of doses? How do you target the people that will have received the vaccine? Thank you.
Thank you. Yeah, a very good question. In fact, as I mentioned, target population and microplan development was based on bottom-up approach. It means like target was calculated at local level and then it was compiled to district and regional level. So that approach was close to reality, although there was risk or chances of wastage, but it was minimized at that context by this approach. The other one, like just mitigation, the Ministry of Health with other partners like WHO has staff in all districts at that time, and also other partners were engaged. So they were also providing data from the local contracts, like polio program, polio campaigns are still ongoing in Somalia. So that was another source of information for calculating the target population for each district or below district.
Okay. Thank you very much, Dr. Farid, for a brilliant presentation, and also thank you to the participants for an engaging question and answer. So next we'll have Prof. Greg take us through the immunization agenda for Africa and looking at the past, the present, and what we can expect. So, Prof, Dr. Farid was 10 minutes ahead of time.
So I get 10 minutes more.
No, so
Wonderful.
let's see if he can beat that.
No. As I said last night, I have a tendency to go on talking forever. So thanks, Dr. Farid, for giving me another 10 minutes. So Ben spoke to you last night about joining the dots and the importance of joining the dots. So I'm going to try to join the dots in the context of immunization in the past, to look at the present with an idea of what we need to do in the future. So my presentation is going to cover quite a few themes, looking at the value of vaccines, a bit about the history of vaccines, the evolution of EPI programs in Africa, which is, EPI programs globally and specifically in Africa, and then talk a little bit about the Immunization Agenda 2030 framework and situated within in the African context. And then along the way, we will look at achievements, challenges, and lessons learned, and so forth. All right. So just briefly looking at the value of vaccines. I'm just putting my time on, so I don't exceed my time. This is a slide from the CDC recently, looking at the current cases of significant vaccine preventable diseases, the 2024 reported cases. And you can see that they compared it with the cases prior to the introduction of vaccines in the States. And as we know, the US has probably the most extensive and comprehensive immunization programs, one of the best globally. And it's compared with the annual morbidity in the year prior to the introduction of vaccines. So, for example, if we look at measles, that figure of 530,000 was in, I think, 1967. They introduced the vaccine in 1968. And you can see in 2024, there were only 266 cases. So looking at that selection of vaccine preventable diseases, we can see that the decrease is virtually 100% in most cases. So there's one that is an outlier, pertussis, which has been, the vaccine as part of DPT has been used for, since the 40s, 50s in the US, and since the 70s in Africa. But it only shows a decrease of 82%. So why? Why such a lower percentage decrease compared to measles and polio and congenital rubella? The thing is, you people have to answer questions as well, not only the presenters. And we can't go until you answer. So as somebody said, there's no wrong answer. Come on. Sorry? Why is the percentage decrease for pertussis only 82% compared to the others, which is virtually 100%? Okay, Ina. A very good answer, because pertussis can occur in the first month of life because the mother doesn't have immunity. And that's why, as you'll hear later on this week, vaccination of a pregnant woman against pertussis is important. And that's happening now, certainly, hopefully will happen in the future in Africa. Anything else? Yes, go ahead. Please shout, eh?
What the percentage of the time that is at peak. So the 12-year-old don't
Yeah, so the principle is waning immunity, and you have to give additional doses to boost the immunity. So those are two very good examples. And the third one is, in fact, that there's been a change in pertussis vaccines used, certainly in the States, where they moved from wholesale pertussis to what is called acellular pertussis vaccine. And that may be a reason why there's also a decreased efficacy of the vaccine and that you require more doses of the vaccine. All right, so you are with us this morning. So just continuing the theme of the value of vaccines, in 2020, the World Health Organization published its 10, 12 most pressing global health issues to be tackled in the decade of the 20s. And as we know, in March 2020, COVID was declared a pandemic. And if you look at those 3, 6, 9, 12, 13 global health issues, immunization plays an important role in the context of each of those 13 pressing global health problems. And you'll hear more about it as we move forward this week. So, for example, preventing antibiotic resistance. There'll be a talk about how vaccines contribute to preventing antibiotic resistance. And then all of you are familiar with the SDGs. Who's not familiar with the SDGs? The Sustainable Development Goals, all right? For those of us who have lost track of the SDGs, please go and look at the SDG list on the UN website. But the SDGs are a collection of interlinked global goals and was set up in 2015 by the UN General Assembly and is intended to be achieved by 2030. And immunization contributes and is relevant to 14 of those 17 goals. All right, so immunization is extremely important, and we'll come back to the issue of the value of vaccines as we move through the talk. Very briefly, a brief history, and this is from the WHO website. Our history of vaccination is very Eurocentric. And, you know, we all believe that Edward Jenner was the person who made the first vaccine in 1796 by vaccinating this 14-year-old boy called James Phipps, sorry, the 80-year-old boy. But we know that, you know, going back centuries, people have in fact been immunizing through inoculating against smallpox. And in fact, this is an interesting story talking about the African origin of vaccination. And I recommend that you go and read. I've given you the references, and don't worry, all the presentations will be made available to all of you at the end of the course. But Onesimus was a slave who was taken from West Africa across to the Americas, and this predates Jenner's discovery of smallpox vaccine. And essentially what he did was to teach the Americans how to make vaccines. All right, so Africa has, from Africa, there's a rich history of vaccination going back centuries. So let's assume that Jenner was the first person who made the vaccine in 1796. You can see that over the last few centuries, there have been a number of vaccines made, 9 vaccines in the first 130 years since Jenner made smallpox vaccine, and in the last 30 years, more than 40 vaccines in 30 years. And the reason for that is the fact that there's been significant development of the biotechnology industry. And this slide, some of you may be familiar with, and you'll hear more about it later on. This just looks at how long it takes to make a vaccine, and most vaccines take anything between 3 and 30 years to make. And given the evolution of biotechnology, science, etc., if we look at the SARS COVID-19 vaccine, it took essentially a year from the first case to in fact come up with a vaccine. So there's been tremendous advances in terms of innovation and technology. So while we're talking about vaccines, don't forget that there's also been a revolution in terms of immunization practices. And we're talking about, for example, new ways to deliver vaccines. And this is just a shot of a screenshot of a trial that happened in the Gambia recently, looking at micro patches. So traditionally, vaccines are either given orally, like oral polio vaccine, or by injection, measles vaccine. And injectable vaccines are difficult. They're difficult to give. You need trained personnel. And there's been a lot of innovation looking at, can we make it simpler by just putting a little patch, for example, on the arm and delivering a vaccine that any healthcare worker or your grandmother could do. All right. So there has been significant advances in terms of how to administer vaccines. And then obviously there's been a revolution in the cold chain. We're looking at how to keep vaccines out of the fridge, because we know in many areas we don't have electricity. All right. So how do we keep our vaccines cool? So there have been a few vaccines that are heat stable. They don't require to go into the fridge. The left's been a bit quiet. So do you have an example of, or do you know of a vaccine that can be kept out of the fridge? Come on, you guys from North Africa. Who was involved in the campaign?
OCV?
Sorry?
OCV. Or cholera vaccine.
No.
Can we use a mic for the online participants? Sorry.
I was just saying there's a lyophilized version of IT93 vaccine for TB.
Okay, but that's still in development. I'm
yeah.
talking about current.
Okay.
Current vaccines. Okay, who's been involved with the Men AfriVac campaign? The meningitis campaigns in the meningitis belt. All right. So the conjugated meningococcal A vaccine is heat stable, and there's also a rotavirus heat stable vaccine. All right.
I was going to say some of the pentavalent formulations have been heat stable.
Yeah, in development. All right. Okay. While we're talking about vaccines to prevent infectious diseases, there are also vaccines that are being developed to prevent cancers. We already have 2 preventative cancer vaccines. We have hepatitis B vaccine that prevents liver cancer. We have HPV vaccine that prevents cervical cancer. And there are other vaccines that are being developed to prevent cancers in general. All right. And then to complete the picture, there are a number of vaccines in development, and you'll hear more about that later on. And TB is, for example, new TB vaccines is an example. We have a current licensed BCG vaccine that's not very effective, especially in adults. And you'll hear all about the new TB vaccine that's currently being trialed. But the whole host of vaccines that are currently in development, and it ranges from group A strep to dengue, etc., etc. All right. So the World Health Organization currently recommends vaccination. They're the group that makes the policy for vaccine use globally. And there are universal recommendations, and there are about a dozen vaccines that are universally recommended by WHO, and there are another 15 plus minus that are recommended for regional use or for at-risk populations. So, for example, you'll see on the list here, yellow fever is used extensively in West Africa. We don't use it in Southern Africa because those mosquitoes haven't been able to move south as yet, except on the plains. So we've had a few cases of yellow fever in travelers, and you'll hear more about that. And WHO publishes position papers on vaccines, and they update the information on those position papers when new evidence becomes available. If there's nothing else you learn this week and you want to learn about a vaccine, this is your first port of call. Look at the WHO position paper on vaccines, all right? Be it hepatitis B, dengue, cholera, whatever it is. It will give you all the information in a nutshell as to the epidemiology, the actual disease, et cetera, and indications specifically. So look at the position papers. The three in blue, COVID, Ebola, and chikungunya, there aren't position papers for that specifically, but there are recommendations from WHO, right? So there are recommendations there have been recommendations for COVID, and there are recommendations for Ebola and chikungunya, but it's not a classic, what is called a classic vaccine position paper. I just want to mention the issue of vaccine equity, all right? And there will be a talk on vaccine equity later this week. I think Radzani is doing the talk on vaccine equity. And this slide just shows you from 1970, when the EPI started, the global EPI started in 1974 to 2020, 2024. You can see in blue are the vaccines available to children, specifically in Africa. So currently, there are some countries in Africa that where children receive up to 12 vaccines. Many still receive only 8 vaccines. And if you look at children in the US and Europe, they receive up to 18, 20 vaccines. So there's a vaccine gap that exists. And that's because of the issue of equity, all right? So we're talking about children in Africa not having access to, for example, hepatitis A vaccine, varicella vaccine, influenza vaccine as a routine, all right? And then this is an interesting paper looking at vaccine coverage in Africa and the issue of inequity. And on the left-hand side, it shows the vaccine coverage by country, and they, in fact, this is all what I call hard data, good data from demographic health surveys and national surveys, and it looks at the vaccine coverage, and you can see it ranges in Guinea from 20% to Rwanda up to 80%, okay? So Rwanda in this analysis had the highest vaccine coverage compared to Guinea, the lowest vaccine coverage. And on the right, they look at the issue of the countries receiving full vaccination in relation to what is called the concentration index. And the concentration index is essentially a measure of inequality that really quantifies how outcomes are distributed across socioeconomic groups. So a concentration index that is positive on this side of the graph can be regarded as being pro-rich. So what this would basically mean, if you take let's just use Guinea as an example. You can see that the concentration index is to the right of 0. It basically means that poor children are not having access to vaccines, right? And it is interestingly in this analysis, the 2 countries that were pro-poor, right, and no discrimination were the Gambia and Namibia. So well done to them. Okay. But it's a useful tool to think about inequity within countries in relation to vaccine coverage. And then we all know the issue of COVID, right? I mean, most of Africa didn't see a vaccine, right? And on the left-hand side, you can see the coverage. And this was more than a year post-introduction of vaccines, coverage being less than 20% compared to our high-income countries' coverage over 80%, right? So coming back to the vaccine position papers, the most latest one is, in fact, the position paper on respiratory syncytial virus, and you'll hear more about RSV vaccine later this week, and this was published in May 25. So the first sort of schedule, I mean, vaccines have been used, as I said, for decades, in fact, centuries, but the first actual schedule or recommendation came from WHO in 1961, right? And you can look at this at your leisure, but it includes smallpox, polio, diphtheria, pertussis, tetanus vaccines. All right, so that was in 1961. But remember, as I said, vaccines have been used in the past, and I just want to make the point in terms of smallpox that in the 30s, in the 40s, smallpox vaccine was being manufactured in West Africa, all right, and used in Africa. And you can see in this graph here, when they introduced smallpox vaccine, the disease declined quite dramatically. And the same applies to yellow fever. So yellow fever vaccine has been used for many years, going back to the 40s in Africa. And in fact, Max Tiller, a South African, developed a safe and effective yellow fever vaccine in 1937 and won a Nobel Prize for that. And then BCG vaccine has been used for decades, long before the EPI was launched in 1974. So the expanded program on immunization was launched in 1974. It was built on the success of the smallpox eradication campaign, and the objective was to raise the immunization coverage with expanded number of antigens. And at that stage, it was estimated that less than 5–10% of children were getting the 6 basic vaccines that were available at that stage. Okay, and the vaccines then were BCG, diphtheria, tetanus, pertussis, oral polio, and measles. And the strategy that was highlighted by WHO was a routine vaccination service with supplementary services like campaigns and catch-ups. And in WHO, I have published recommendations for immunization, both in the context of universal and in the context of at-risk populations. This is our schedule in South Africa, and we have a routine schedule that's given to children. And we also have a schedule for adolescents and adults, but that's mainly for people at risk. And we spoke about pertussis, and we have just introduced Tdap to pregnant women in South Africa recently. All right, so coming back to the value of vaccines, we know that the EPI program was launched in 1974. And this was 2 recent papers from the Lancet and the BMJ celebrating the successes of the EPI. And the paper in the Lancet was a modeling exercise, and the authors concluded that we've averted over 150 million deaths globally as a consequence of the use of vaccines. So you're looking at 3 million deaths or 3 million lives saved every year as a consequence of immunization. And this is a good paper to review. It talks to the EPI, a legacy of 50 years and the road ahead. And it talks about the successes and the key achievements of EPI over 50 years, talking about the dramatic improvements in child survival, that immunization has contributed to a 40% decline in global under 5 mortality. It talks to the issue of disease eradication, and we know that smallpox was eradicated in 1980. Are there any other infectious diseases that have been eradicated? A trick question. I hear murmurs. Sorry? I said smallpox was eradicated, so besides smallpox, nothing else. Nothing else. Huh? Rinderpest doesn't happen in people. It's related to measles, but no, malaria has not been eradicated. Wild polio, yes, not 1 in 3. You heard Dr. Farid talking about wild polio in Afghanistan, which means you weren't listening. Polio 2 and 3. Okay, and a free lunch to tell us when did that happen? Polio 2 was eradicated in? No, 2015. Okay, and polio 3 in 2019. Okay, my brain's still functioning. All right. Okay, so read this. It talks about global reductions and key innovations in the cold chain. All right. These are the global strategies over the last 5 decades. All right. And we started in 74. In 82, we had the Universal Childhood Immunization Initiative. 5 minutes remaining. Wow. 1-5. 15 minutes. Oh, thought power. Okay. So we had the Universal Childhood Immunization. We had the Children's Vaccine Initiative. We had the GIVS in 2006. We had the Decade of the Vaccine in 2011. And if you're a cynic like me, you said, what the hell? They're all the same. Okay? Because all of them are trying to promote immunization globally. But there have been strategic differences in the approaches. All right? And the most recent one was the Immunization Agenda 2030, launched in 2010. And that superseded the Decade of the Vaccine. Decade of the Vaccine had superseded GIVS, et cetera, et cetera. And significantly, the Global Alliance on Vaccines and Immunization, which was launched in the year 2000, has played a major role in immunization on the continent. So that's the global initiative. And I've given you the references and go and read them because it makes for interesting reading, right? Go and read up around them. I mean, going back to the UCI initiatives in the 80s. This slide is a bit busy, but it shows the African initiatives in blue, the more recent ones. The African Vaccine Regulatory Forum, the African Vaccination Week launched in 2011, the Addis Declaration on Immunization, the business case for WHO immunization, and then the African Implementation Immunization Agenda 2030 framework. And I'll briefly mention some of them moving forward. Gavi is important. You're going to have a talk on Gavi, and we have a Gavi person sitting somewhere here. Okay. And she'll be able to also talk to you about Gavi and what Gavi has done for vaccines in Africa. And Gavi supports countries, and to be eligible for Gavi, you have to have a gross national income per capita of about 2,300. And this is for next year. It's actually gone up a bit, and that's to cover more countries in Africa. All right. And Gavi doesn't only support introduction of vaccines, but it also supports health system strengthening and other issues. And this slide just shows how the Gavi vaccine portfolio has grown over time from the year 2000, when they had 6 vaccines available. And this is the Gavi version 6.0, looking at the year 2026 to 2030, where there will be about 25 vaccines available in their portfolio. And what's interestingly about the Gavi 6.0 initiative is that they've included 2 vaccines that are not yet routinely used. So this talks to tuberculosis, and it talks to Group B strep, all right? And you'll hear about TB, and you'll hear about Group B strep. And what I like about this initiative for the Gavi 6.0 is that they're saying that these new vaccines are probably going to be included sometime in the next 5 years into routine immunization programs, although they haven't even gone through a comprehensive phase 3 vaccine clinical trial. Okay, so that's optimism for you, which is fantastic. All right, the Immunization Agenda 2030 is the program that WHO is coordinating, and their vision is a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. It has a number of impact goals, which I'm not going to go through, a number of strategic priorities, core principles, and it really builds on the success of the Global Vaccine Action Plan, which was the predecessor to this plan, going from 2011 to 2020, and it's aligned with the SDG number 3. All right. UNICEF have a similar road plan, right? And they sort of are in line with WHO, and their vision again is similar to WHO Immunization Agenda 2030, where every child, every person, woman, adolescent, etc., benefits from vaccination. And just for those of you who may be a little bit confused about what do these two big agencies do, right? WHO on the one hand is the agency that sets policy, okay? It provides global health policy and technical recommendations, whereas UNICEF is involved with programmatic work in terms of purchasing, delivering vaccines and equipment to developing countries, especially in Africa. Okay, so it's policy and practice on the other hand. Coming back to Africa, just very briefly, there was the Addis Declaration on Immunization. And this was supposed to be a historic commitment from African heads of state in 2017. All right? We don't have time to go through the commitments from 1 to 10. All right? Arising out of the Addis Declaration, specific milestones were supposed to be set. All right? And to guide the process for reaching those specific commitments. But I must say, there's not much has been done about it. And it comes back to this issue about declarations, about strategies. You know, we tend to sit around the table, make a decision to do something, and very little happens. And I'm being quite crude now, and don't quote me on this. I often say to people, they sit around the table, and I'm not sure what the hell they're smoking. You know, you come up with some ideas, and it doesn't happen, right? But I think it's important. It's a very important declaration, because I think for the first time, there was a unified declaration from African heads of state that we had to do something about immunization on the continent because we were failing our children, right? We had to increase delivery. We had to increase investment, especially domestic investment in immunization, and not be solely reliant on the Gavis of the world, etc., etc. All right, so that's the Addis Declaration on immunization. We had the business case for immunization activities on the African continent, labeled 2018 to 2030. And the document provides a framework for achieving universal immunization by 2030. All right, and I'll come back to this in a minute. And then they also developed in that business case an immunization maturity grid. And they identified components of the immunization system, which are listed there. And they were hoping that by 2030, that all countries would reach a satisfactory level of immunization maturity. And then there was the framework for the implementation of the Immunization Agenda 2030 in the WHO Africa region, which was adopted in 2021. And you can't read this because it's too small, but it talks to the vision, goals, objectives, specifies specific targets, milestones, and this was all in relation to how the African EPI community looked at the the Immunization Agenda 2030 as adopted by the World Health Organization. We have African Vaccination Week that is celebrated in the last week of April throughout the continent. Overarching slogan, vaccinate communities, healthy communities. We have the African Vaccine Regulatory Forum established in 2006, which attempted to enhance collaboration between regulators and ethics committees. You'll hear a lot about the PAVM, the Partnership for African Vaccine Manufacturing. On Wednesday, there's a whole session about the need for Africa to develop indigenous vaccine development capacity. Gavi has been involved in accelerating vaccine manufacturing on the African continent, and last year they allocated over $1 billion for this initiative. And then there's the African CDC, which is the only continental Pan-African health institution, which is also trying to strengthen public health and support not only health workforce, but also looking at the manufacturing and delivery of vaccines on the continent. And then there have been a whole host of disease-specific and other initiatives on the continent, from polio eradication, measles elimination, TB control, etc. And you'll hear a lot about these things as we move through the week. I'm going to skip a few slides because I need to move towards the end of my presentation. And this one just talks to the evolution of the role of science and clinical trials on the continent. This slide just talks to how Gavi has impacted on the introduction of new vaccines on the African continent between the decades 2010 and 2020. This just talks to the impact of EPI in Africa, looking at how EPI in Africa have saved over 50 million lives. And remember, you know, Africa is home to 25% of the world's children, and more than a third of the global lives saved have been in Africa. Disappointingly, Africa CDC just said recently in April 25 that over 500,000 children under 5 continue to die annually from vaccine preventable diseases. And that's disproportionate in terms of the number of children in Africa compared to the rest of the world. The reason for that is children are still not being vaccinated against diseases that have been around for centuries, and vaccines have been available for years: rotavirus, pneumococcus, HPV, and you can look at that later on. And it's just encouraging to hear from Dr. Farid that Somalia has introduced rota and pneumococcus vaccine just recently into the EPI program. We've heard about the outbreaks as a consequence of a whole list of reasons, including climate change, misinformation, conflict, humanitarian crises, and so forth. Just in terms of success, what's happened? All right, it's not all doom and gloom. The following two slides just talk to the immunization agenda 2030 goals and indicators. And we can see that for most of the indicators in terms of the prevention of disease, we're off track, and Africa is a contributor to that. So we're off track in terms of death aversions, achieving eradication and elimination goals, etc. We're off track in terms of the issue of equity, and we're off track in terms of building stronger immunization programs. You've seen some of these slides from Dr. Farid for the WHO EMRO region. This is a similar graph looking at the coverage for the different vaccines, DPT3, MCV2, PCV, and HPV in the African region on the left-hand side compared to the other regions. And you can see that Africa, specifically for DPT3 and for PCV3, are worse off than the rest of the other WHO regions. You saw similar slides in terms of the issue of the zero-dose children, and Tony later in this week will have a lecture talking specifically about the zero-dose problem on the continent. I want to point out that South Africa, my country, is ranked 15th on the list of zero-dose children. Okay, and it's really terrible that South Africa, with all its resources, in fact, has this problem of children not being vaccinated. In terms of immunization maturity, in 2018, WHO did this wonderful study looking at systems, immunization systems across the continent. And they categorized them from weak to robust systems. South Africa sat here in the middle in terms of category 3. areas that targeted for improvement. The problem is that this was 2018. I'm not sure how this pans out at the moment, because they haven't done something similar to looking at, has there been a maturity of systems? And I don't know, maybe Jason can comment on that later on after the presentation in terms of what's happened with respect to maturity of immunization systems across the continent. And this was in the context of the Addis Declaration on immunization, a wonderful study done by our good friend Charles Wisongi et al., looking at one of the indicators, and they found that only 7 out of the 54 countries in 23 achieved at least 3 of the 4 indicators to measure the 4th ADI commitment, and the countries are listed there. And they were looking at issues around coverage of vaccination for DTP1, DTP3, MCV, and so forth. So in summary, last 3 slides. Immunization is estimated to save over 3 million lives every year. The global, continental, and regional and local immunization goals attempt to work towards health equity in terms of immunization. And despite all the problems we have, there is good collaboration between countries and agencies and communities across the continent. And this is important for successful immunization programs. There are a whole host of challenges, and we need to address these challenges. And I'm just listing some of them here. We need to strengthen health systems and primary care. And there are a number of you in the room this morning who indicated your interest in strengthening health systems, so maybe you can comment on that. One of the goals of the ADI, the Addis Declaration, was the need to increase domestic funding, and I'm not sure that this has happened. All right, so we need to increase domestic funding for vaccines and immunization services. We need to devise innovative strategies to reach zero-dose children, and we'll hear hopefully more about that later this week. We need to address the issue of vaccine preventable diseases outbreaks. We'll hear about vaccine hesitancy. We need to scale up implementation science research. My good friend Charles Wisongi, who was the director of immunization services in the Afro region, is a person very keen in the context of the role of implementation sciences, and in fact published a paper recently on how we should use implementation science to promote vaccine development. We need to encourage collaboration and support from regional health organization. And as we heard from Dr. Farid, the issue of resolving ongoing conflicts and regional, and humanitarian crises. And then just lastly, I think we need to shift our mindset as well to reimagine immunization as a catalyst for resilient and equitable health systems. And this is a paper that Charles and et al., including myself, we're currently writing, and it's up for review with one of the journals. And the bottom line is what we're saying is that immunization must transition from a vertical siloed delivery model to an integrated people-centered approach embedded in primary care and multi-sectorial platforms. So that's the first point. And the second point is that program success shouldn't just be measured by the issue of how good our coverage is, but we need to incorporate issues around equity, resilience, and other process indicators, and coming back to the issue of supporting this by implementation science and so forth, and that it should be reframed as a whole society development priority with political leadership, okay? And the issue of political leadership comes up every time we talk about immunization in every single forum. But yet, personally, I think that we are still lacking the political support that we need. to make a difference in immunization on the African continent. Thank you, Madam Chair.
Right on time. You are probably 30 seconds over time.
Oh, thank you very much.
So we'll have questions from the floor. Just raise your hand. This side.
Thank you so much for the presentation. Mine, maybe it's not a question, it's just a clarification. I'm Fatima from South Sudan. So I can see that in one of the slides, it's mentioned that South Sudan have not yet introduced
rotavirus.
Yes, we have. It has been announced during African Vaccination Week. So we have introduced vaccine, PCV and rotavirus. And we have introduced also the second dose of measles. So effective, we start getting report from October, late September. People start to report on it in our database. Except some counties with conflict there, why they cannot be, the vaccine cannot be transported there. But initially, now rotavirus is effectively there, and PCV is effectively there, and then the second dose of measles as well is effectively being in South Sudan helped.
That's fantastic, and thanks for the clarification. Just to tell people that slide was made in 2023. And on the slide, I tried to look last night which countries. I'm not sure if I tried to make a mark on some of them to say that they haven't just, but that's fantastic news. Well done.
Thank you so much.
Thank you very much for a wonderful presentation. Mine is also similar to her comments. Nigeria was also
HPV.
HPV, yes, but rotavirus as well. We introduced rotavirus 2020, August 2020. So I noted Nigeria was not in that map for rotavirus. And then secondly, I want to, there was this interesting slide you put up on countries ranked according to the DPT1 coverage and absolute zero, number of zeros dose for children. You know, there was someone that made a comment over there asking about DPT 1 versus 3 and how we pick the one we use for all this, you know. But interestingly, again, I noticed Nigeria is ranking #1 on that slide. And for me, it's worrisome. I'd like you to throw more light on this particular slide. Thank you.
Okay, so I don't want to steal Tony's thunder. Tony on Thursday is going to talk about the problem of zero-dose children, all right? And maybe we should save some of those questions till then. But the issue of just to clarify about DTP1 and DTP3, Dr. Farid tried to clarify that. And generally speaking, DTP3 drop off, I mean, DTP3 coverage is usually less than DTP1 coverage. Okay, I think that's a universally accepted norm, okay, because people generally, despite all the problems they may have, the first contact with EPI is the 6-week visit, and mothers, caregivers want to take their children to the clinic, and then they get, if I could use the term, bored for all sorts of different reasons. They don't take the kids back, all right? And we've used those indicators as a sort of, you know, DTP3 coverage as a measure, a marker of maturity of the EPI program, all right? So that's the issue between DTP1 and DTP3.
Hi, thank you so much for your talk. I just was wondering more around, so not exactly how to phrase this, but in terms of balancing healthy competition, you know, competition drives innovation and you want to get the best ideas, but also not spending a lot of money on ideas that then don't go forward. How do you balance maintaining competition and not having competition that then leads to like wasting funding or things that then don't progress further than where you want them to go?
Are you talking about competition in the context of vaccine development?
Yes, yeah.
Okay, all right. As I said, I don't answer all the questions. You people answer all the questions. So anybody, come on, you guys in Biovac and Afrigen. There's a good question for you. How do you balance that issue of money in terms of ideas?
Well, I think specifically for the African context, a lot of the funding is external usually. And so if you're looking at like $1 billion that have been allocated, you want to make sure that the money is spent effectively rather than, but you also want to have best vaccines coming through, if that makes sense, while also not, developing 100 projects and then only, yeah.
So there's a whole process in terms of vaccine development, and it essentially starts with the need. Okay, do you need a vaccine for disease X? All right, how and if you're talking about disease X, how does disease X fit into your country's specific needs? So you need to rank the diseases. So it's about prioritization. So you need to say disease X, and how do we prioritize them? All right. So we prioritize them in the context of burden of disease, one example. All right. So if you take South Africa, right, the big killer now, the two big killers are still tuberculosis and HIV. So those are national priorities. They're probably continental priorities as well. In the past, it was, issues relating to diseases like rotavirus and pneumococcus, right? So I am not going to prioritize, if I was the Minister of Health in South Africa, and I'm trying to use an example. Okay, I'm not going to prioritize chikungunya disease in South Africa because the mosquitoes don't live here, so why should I? It's not a problem. It's not a problem for us. And even if the disease was occurring here, that disease is relatively mild. Sorry, my alarm's going off. The disease itself is mild, even though you could have thousands of cases. So it's about prioritizing in terms of the prevalence of the disease and the severity of the disease, right? And then you also have to prioritize on the basis of what is the potential success in terms of making the vaccine, right? In the past, it was easy. You could just take the bug, inactivated, you're talking about live viruses or bacteria, you could, throw it in a flask with some formalin and you inactivate the bacteria and you have a vaccine. Being very crude, modern technology is obviously more expensive, etc., etc. The easiest vaccines have been made. We're sitting, and you'll hear about the difficulty in terms of making a TB vaccine and HIV vaccine because of the fact that there are multiple antigens, etc., etc. So prioritization in terms of making vaccines and not wasting money is important. And I think you're looking at agencies that where people have been interested in making vaccines for the benefit of people as a whole. And just lastly, before other people talk, is that there is a global committee, the Product Development Advisory Group that sits within WHO, looking, and I showed you a slide of the pipeline vaccines. So they oversee the evolution of pipeline vaccines, and they make recommendations to WHO as to say, look, I don't think we need to be wasting money on disease X, rather focus on disease Y and get Uncle Bull to shift his money from X to Y. Sorry, a long explanation.
Thank you, Prof.
Thank you.
So I know we have a lot of questions. I have to apologize. We have to move on to the next presenter because they're presenting online. So time is a bit sensitive for them. But for those who had any burning questions, please see Prof during lunch. if you need clarity on some of the issues. There was a comment online on vaccine hesitancy and challenges. I just want to say there will be a session on that later on in the week. So those questions will be answered. So we will now have Dr. Nikais Ndembi, who is a Deputy Director of the International Vaccine Institute in the Africa Regional Office based in Rwanda. So we just want to say we appreciate you taking the time, Nikais, because from what I hear, you are in Asia and it's very late that side. So thank you for agreeing to do this for us. Yeah. So can you
Great.
just-
No, always a pleasure. Always a pleasure. I hope you can hear me.
Yeah, we can. Great. Go ahead.
No, excellent, excellent. I think good. Let me get started. Let me get started with probably answers to some of the questions from the previous sessions. I think what you have now on the screen is a risk ranking and prioritization of epidemic-prone diseases. And this is particularly for the continent in Africa. I think if you look at it, those days when I was still with the chief science officer with the Africa CDC, we started connecting dots together. This is a continent that has experienced several outbreaks and recurrence of outbreaks since the 1960s. But again, we wanted to put longitudinal data in terms of frequency, in terms of risk trajectory, epidemic potential, disease severity, and preparedness by diseases. I think if you look at it clearly, most of those are also preventable diseases. I think you can look at it on the x-axis, and then on the y-axis you have those scores, right? So and it's quite important if you look at it from a continental perspective. I think you can actually, you may have realized that outbreaks are getting closer and closer. Those days actually, the time between two outbreaks like a decade. Now a decade, like now we have like every single year. We just ended the Marburg in Rwanda. We had to deal with Ebola in DRC. I think it's quite frequent now. I think that's you all agree. Really, global warming. I think it's playing a key role in here, and then I mean that we're getting closer and closer to the human habitat in terms of risk. So I think this is the first stop. So we really need to document. We really have to see what are the what is the disease burden. I think being sure that we develop at least vaccines or putting resources for R&D where we have the frequency in terms of also volumes, right? Because a manufacturer will not embark into any of those diseases if they are not of public health relevance and not commercially viable. So that's the first thing. I think if you look at it, cholera, for example, on the third line on the slide there, you can see it's still at very high risk. If you look at cholera next to chikungunya there, it's very high risk. I think if you look at the disease severity, still very high score, 3.5. If you look in terms of preparedness, in terms of how prepared are we, in terms of response to cholera outbreaks, we are not well prepared. So next. So if you look at it now from a different perspective, on the y and x axis, I'm just giving you an example on cholera to show you exactly where we stand as a continent. Still very high in terms of risk epidemic potential, in terms of scores. So, and in fact, for the past at least 2 decades now, at least 20 African Union member states are experiencing outbreaks of cholera every single year. At least 20, as we speak, 23. And this is a disease that actually, the last outbreaks in the US was in 1911. And the last outbreak in the UK in the 18. So you understand We really want to understand what's going on. So, okay, we can agree that some of those, the Rift Valley fever, the monkeypox, the chikungunya, and so on, I think there's no much interest there probably from the commercial perspective. But you see cholera, it's a disease with a vaccines, preventable vaccine disease. I think something's wrong. And this is where it's wrong. And the presence of Zambia, which is the Africa Union champion for cholera, and the WHO DJ, I think, really published an op-ed last week. And the question there, cholera is spreading fast, yet it can be stopped. Why haven't we really concerned it into history? I think this is a valid question, and we're just trying to answer that question in the subsequent slide. And again, this is again, I really the previous speaker justice to that very good. I think we need to look at the mortality, the prevalence, the burden of infectious diseases. I think again, this is important in our own context in terms of prioritization. And then this is what's not happening currently. We are not prioritizing for research and development, diseases of high priorities for this continent. And then we're dealing with those on actually the daily basis. The AP program, they're overwhelmed. If there's outbreak of cholera, usually the vaccines get into the field when the actually prevalence have subsided. So how do we solve this? Neither we get really probably what we call a stockpile on the continent to respond. Every single outbreaks, and we know when they occur, the vaccines always get late, getting late to people and getting late to be deployed in our rural areas. I think that we need to resolve this. So if you look at these data, actually published also by Nature a few months ago, in terms of prevalence on the y-axis versus mortality, the bigger one there, the bubbles, the blue ones, at least we have vaccines there at some extent, but again, these are actually where the burden is. We're still working on some options for vaccines for TB, optimizing vaccines for malaria, but overall, the gray ones are those we don't have the vaccines. The previous speaker did mention HIV is still high burden on this continent, TB and others that you see on this slide. I think this is where we really have to move really the conversation, particularly for low middle income countries. Now, I think again, justice to the previous presentation. If you look in terms of mortality, even child mortality, because you look into really, if you want to move this ecosystem, availability of vaccine for immunization, you look at the childbirth cohort. How many new children are born in Nigeria, which has really the largest population in Africa, for example? I think you start looking at the important, the relevance, really looking at mortality, really child mortality. Nigeria is the third with the highest birth cohort after India, China, for example. It gives you an idea of where we are. So you see really high mortality, I think, across board there. If you look at the top line there, the purple ones, you see more Africans countries than some in the rest of the world. That's something we need to resolve. But what are the compelling issues here? I'm gonna talk a little bit more about that. So, but again, numbers, they don't really rely on numbers. Very important. Whatever we do should be guided with numbers. I think so that you build strong assumptions in what you're doing, even if it's modeling. So if we look again, number of lives saved by childhood vaccination. Very good news. We need vaccines. 154 million. That's the total across board, at least from 1974 to 2024. You have all seen this data. I think this is power of vaccination, immunization. Again, among children. That's very important. So I think let's shift the needle. We know now we need vaccines. Second, we know that we're not doing very well in terms of child mortality across board in low middle income countries, including Africa. We know where the burden, the prevalence is, but how do we do now to get the vaccines to those people in terms of prioritizations? So the Africa Union, why at the Africa CDC during COVID, we came to the realization we only manufacture 1% of all the vaccines that are currently being used for childhood, adulthood immunization in Africa. Only 1% currently manufactured on the continent, 99% imported. So it means that we're missing something here. Manufacturing is not happening where the center of action is actually been, where the really action is taking place, where there's a high burden. So I think there was a plan from the AU, the head of state, to really set a target by Horizon 2040. The plan is to manufacture 60% of those vaccines in Africa, and then by 2030, 30%. I think we are making good progress there. When we launched this program, when I was with the Africa CDC, Africa Union, they were really, as I've said, only yellow fever vaccines, a drug substance manufactured in Africa. Now we have 8 antigens ready for 2030. That's a good progress. We want to see more by 2040 so that we can really getting the vaccine closer to our own populations, getting the vaccine ready for use and deploy when needed for prevention of outbreaks across the continent. So those are the 22 diseases that have been prioritized. You can see clearly at least those ones that have been discussed previously in there, including HIV, chikungunya, Rift Valley, Lassa fever for outbreaks. These are outbreaks, not necessary for routine immunization. The first block on legacy are those ones currently used for routine immunization. So I think this is going to require a combination of different innovative technologies, both traditional and innovative, including mRNA technology, viral vector, virus-like particles, subunit, inactivated virus, and live attenuated. This is what's going to, that combination that's going to take us to Horizon 2040 at that 60% target. So what do we do as IVR, the International Vaccine Institute? You all know we have a cholera vaccines developed by the Institute of Human, the International Vaccine Institute. Now the tech transfer to BioVac. This is the first tech transfer of the cholera vaccine to an African manufacturer, an African vaccine manufacturer on the continent. And this is to address that gap that I initially mentioned. We cannot be having an issue in Africa with more than 6,000 deaths since January for a disease that has been so far eradicated in the global north, and we're still dealing with no manufacturing in Africa. So this is going to be the second drug substance manufacturer in Africa after the yellow fever. So this is going on nicely, progressing very well. I think just to give you an idea, how does it take? Why didn't we do that before? At least to really develop up to WHO PQ commercial licensure, it's about $28 million. What the original, but that's going to cost less as we transfer this technology to BioVac in South Africa. We have several other vaccines in our portfolio, but basically the message here is not too expensive, because we really develop our vaccines based on the cost for low middle income countries. Some are even less than $5 million. So we need to invest. Why we need to do that? We need to invest into research and development. And this single slide gives you the funders. As you can see clearly, our government is a strong call to invest into research and development for the disease of priority for this continent. You can see the funders are not our government. I think it is a strong call here that we start investing in research, development, science, innovation to drive local manufacturing, and so far, by default, drive also uptake of some of those vaccines for routine immunization. So we're also working with Afrigen for Rift Valley fever vaccines, mRNA technology. As you know, Rift Valley fever is a zoonotic disease primarily affecting animals with a potential to spread to humans. If you look on the map, that map on the right, you can see at least the spread, the spread across the continent, human, animal, and insect, and then also distribution among human and animals alone, and humans. I think it's important that you see the potential for an outbreak here across the continent, because there's a spread, across the different regions. So again, we are looking into vaccines using mRNA technology with our partners at Afrigen. I think a candidate probably towards the end of 2028, early 2029, if the timelines will stick as really planned with our partners. So you can see, I think it's important to delocalize really the manufacturer, to bring the technology back home. The BioVac I mentioned earlier, I think by 2027, early 2028, there will be a cholera vaccine made in Africa and then ready to be distributed on the continent. ready. Now we're currently using one single dose where we should have been using 2 doses because of really the shortage of the cholera vaccines. We're going to fill that gap by empowering the manufacturer with technology, being sure that it's been manufactured on the continent for Africa and for the globe, the rest of the globe. So I think there's no doubt on the value of investing into manufacturing, investing into vaccination. We all see this figure quite oftenly. I think $1 investment, the return on investment is at least $20. And I think you can go further if you look into and really fine tune your modeling. You can get up to $52 really investment from every single dose you invest into vaccination. This is a huge amount of money for a continent spending 800 billion for syndemic, all the infectious diseases that you know. We need to procure drugs. We need to procure diagnostic tests. We need to procure all the vaccines. All our money virtually goes into supplies. We need to stop this. I think you see clearly that there's a value you're investing into vaccination and vaccine manufacturing. So I think there are 3 shifts that we're proposing here. I think we need to transition vaccination from really vertical silo delivery models to a really integrated model. And we've seen that. I think times are not really the same as they used to be. Now we have to deal with the funding cut, 70% ODAs. We need to really mobilize more resources, domestic resources, to be able to support some of those programs. Someone mentioned the Gavi program. We all know the challenges the world is going through, and then also more so vaccination program. So we need to expand vaccination success metrics beyond coverage to include equity, resilience, process indicators, and then some of those digital tools required for monitoring. Again, we reframe the whole of society development to anchor some of the political leadership, sustainable financing, and regional manufacturing that I'm advocating for. So again, if you look at this before we end with financing, so if you look at the historical vaccine funding, and then you tally it with what we usually call the disability adjusted life years by income groups, look at it closely, you can see that the bottom, the quadrant at the bottom, most of those diseases with those bubbles, I think that I mentioned earlier, the larger those bubbles, the higher the burden, the prevalence, and the mortality. So money doesn't reside there. Conversely, the high-income countries there where there's money, there are very few little that need to be done. I'm not saying nothing, but again, most of all the burden is in the low middle income countries, and conversely, little money is being put into to be able to support development of vaccines, which subsequently also deployment of some of those vaccines in low middle income countries. So we all know what's going on. I think we shouldn't leave this meeting, very interesting and important meeting, without really thinking through how do we going to get into the funding cut from WHO, Gavi funding cut, really replenishment. We didn't get to the target. USAID being dismantled. The world is getting crazy, right? So how do we think innovatively? It's very important. So again, we need to start from that unipolar to multipolar, from the global north to the global, not global north only, because I strongly believe we have to contribute as a continent. We need collaboration, cooperation, and then sustainability in our way of dealing with vaccination program. And a new word, collaboration. Don't have to collaborate, but we need action. Take really action seriously in all the collaboration that we're doing. We need ownership from the continent, leveraging on the existing investment, put ideas, innovation, translational research, commercialization of what we're doing to be able to support our entire ecosystem. So there are several models globally. We need to really have a business model for our healthcare systems. I can tell you from where I'm here today, from the Korean model, they do have a model to support and fund research, science, innovation for digital health, diagnostics, vaccines development. In this model, the government put in or support 50% of all R&D projects, the philanthropic organization 25%, and the industry 25%. This is a country that 2 decades ago were manufacturing only 5% of their vaccines. Now they are 70% using this model. Financing is important. Skills development, very important. And then the business model as well. We need to be sure that we have that model on the continent moving forward. I think I mentioned the target, and then we are putting together our heads with government across the continent to see what's happening now shouldn't happen. It's really an opportunity to build a new system moving forward. In conclusion, we really need African-led, regionally connected, and globally relevant solutions to really resolve issues around immunization, local manufacturing, the zero dose. The solution should be really homegrown solutions. So we need political will, financing and decision regarding vaccine demand. We need collaboration, not collaboration only, but collaboration to be sure that we get things done within the regions. We need to develop a business case. Every time we're dealing with a situation now, we need to think about the business model. How do we use efficiently the resources available? How do we really create domestic resources to be able to support some of those programs? Domestic resource mobilization. And then finally, really, I mentioned earlier, silo delivery models. We really have to get rid of it to really have an integrated, people-centered approach. I think this cannot be done, I can tell you from our own experience, without partnership. Major partnerships should be involved into. I think you can see from IVI, where we're developing some of these vaccines, we have multiple partners. Partnerships is key. And then even within countries, across board, across the continent, to be able to really address some of those questions. Again, thank you very much for inviting IVI and myself for this very important meeting. We look forward for really exciting, continuation of this program. Thank you, and back to you, Chair.
Thank you so much, Prof, for that wonderful presentation. Any questions on the floor for Dr. Nikais? We have time, so feel free to ask.
Hello, thank you so much for the presentation. My question is, following the major funding cuts, and maybe it's a little early for this, but are there some examples of new innovative practices to mobilize domestic resources for immunization? Thank you.
Did you get that question, Doc?
Oh, yes. I think let me start with, I think the first thing, there's has been I think the response, the continent responded in a very positive way. And we strongly believe, when I say we, the global health community, there have been a lot of initiatives across the continent. Abuja Declaration, you know that, the Lusaka Agenda, a long list of initiatives. We really want to be sure that those mechanisms are being currently activated. There's now a movement around what we call the Accra Reset, the mind shift. We need to change. We need to take this opportunity to make some of those changes. So I presented one of those models. I anticipated your question. The Korean model, I think it's a collective approach where you have the private sector, you have the philanthropists, you have the industry and the government. I think this is important. I say government because I strongly believe that we're not doing well there in terms of domestic resources. We have seen there are programs across the continent, health program where 80% of the funding were donor funded. Unbelievable. Health is not a charity. I think our government should put in resources to support these programs. I think this is the time now to do so. So back to your question is to put private sector and the government in the equation, not donors. Remove donors as part of the equation. I think if you get it done properly, we should be there in the next couple of years. I think the impact of even this funding cut, I keep saying that, we'll not see it till next 5 years. As we see it for COVID-19, the impact on the zero dose is now that we're seeing that. Now we started actually seeing the huge impact that actually resulted from COVID-19. That's the same with this funding cut. That's going to be in 2 or 3 years that we're going to see the real impact. See, this is a government role and responsibility. I think I'm going to say it several times again. I think there's no other business model than having the private sector at country level, the social corporate responsibilities, and the government back into the equation. Thank you.
Thank you very much, Nikes. This is Jason Mwenda I have two quick questions or comments. One is on the cholera control in the African region. Personally, I believe that we should not be having cholera outbreaks in the African continent, but we do. And the comment on one slide where I think you quoted the president of Zambia and also the DG of the WHO region. I know, of course, we do have the cholera vaccine, but I think the emphasis should be on WASH, clean water and sanitation, and of course, in addition to vaccines. But I think the issue of WASH is not being fully implemented, and that's why we are having these cholera outbreaks. So I'd be interested to hear your comment on that. And then the second one is on the very ambitious goal of vaccine manufacturing in the African continent. Given that the target of 60% vaccine manufacturing in the African continent by 2040. In Africa, I think there's a lot of political pronouncements, but not really backed by action. So do you really think that that target is realistic, that we're going to have 60% of vaccine manufacturing in Africa by the year 2040? Thank you.
No, excellent question. Excellent question. Let me take the first one. No, very excellent question. The first one on cholera, I think 100% agree with you. 100%. I think we're referring to outbreaks here, but you're absolutely right. It's a multi-sectoral response approach that we should be having. I think you're looking at animal, human, environmental, and usually this is being looked at the health problem only. I think we need to work now, I think, in terms of bringing all the ministries that are involved into really sanitation. You're absolutely right. I agree with you there. I think, but usually this comes up when there's an outbreak and then you don't have other preventative measures. Yes. And we've seen that during COVID, when I was still with Africa CDC with leading the continental response for Mpox. It was quite striking that Mpox was actually happening in the same areas with cholera outbreaks. You see? So you are actually on spot that WASH is the way to go. It's the cheapest way to go. But we can actually find a better way to prevent our own population going through this. I say it again, 6,000 people dead since January 1st on this continent for a disease. 100 years that people have been eradicated is unbelievable. So I think all measures are hands on deck to be sure that all measures can be really, all multi-sectoral approaches can be brought into, including WASH, to really get this solved. Yeah, I fully agree with you. So then the second point on 60%, I think you're speaking even to the person that is for my office, the 60% target we're set. So to be quite honest, it's doable. But the point is that we took so much time to identify the quick wins, the enablers. And then we also have a big issue, I mentioned it, the model. You cannot be aspiring to manufacture 60% of the vaccine by Horizon 2040, and you count on donors' money to do so. It will not work. So to set your target, you're going to have your money, your budget and funds allocated to drive this. And we identify those enablers when we set this target. One, the market shaping and demand intelligence. How do we procure through a single procurement mechanism to drive costs down, given the economy of scale? That was the first enabler. We've seen during COVID, it was working very well. There was AMSP developed by the Africa CDC. All member states were procuring through that platform medical countermeasures. They made $10 billion in 1 year. It means that the market is there. We need to, that's number two. We need the second, skills development. We need to train all those scientists in the room there to be sure that we have manpower. It's not AI that's going to be getting us to 60%. No, they are human beings, operators. They're going to sit behind those equipment to move to 60%. We need skills development. We need to finance R&D, research and development. Currently, we're at 0.2% of the GDP allocated for research and development. The growth is at 2.2%. Africa is still at 0.2%. And the AU goal is to reach 1%. If you don't fund research and development, forget about it. It means that there's no innovation, no science, and you remain a consumer of product. because you don't innovate. If you don't fund it, you don't innovate. There's no two ways for that. If you're going to develop the mpox vaccine, you need to fund researchers to do so. If you don't give them money to do so, then you're going to consume all the mpox vaccine in the world. So the bottom line, research and development, we already mentioned, market shaping, skills development, regulatory systems. If you don't have a strong, robust regulatory system like the African Medicines Agency coming operational, the made in Africa vaccine will suffer. We need to be able to compare our vaccines to the vaccine produced in Brazil, the vaccine produced in Europe. In fact, we're doing so. The yellow fever vaccine produced by the Institute Pasteur of Dakar is being shipped globally. People don't care about that because they need yellow fever vaccines when they travel. So I think it's important that we start seeing where the resources can be allocated, how we can make good use of those resources to be able to drive science. We talked about tech transfer and IP. We talked about infrastructure and then a very strong coordination and ensuring that we all work together. No 54 manufacturer or 55 across the continent, but a very coordinated mechanism to get this done. Thanks, and back to you. Excellent question.
Thank you so much for the presentation. My question is, in smaller or resource-limited countries, how can regional collaboration in vaccine manufacturing and cold chain infrastructure be leveraged to achieve collective self-sufficiency rather than isolated national effort? Thank you.
Yeah, again, that's a very good question. I think that's my last statement. As I've said, we do not want 55 African Union countries to manufacture vaccines. That's not going to work. That's not going to work. A fragmented system's not going to be favorable for us as a continent. So what we're advocating is a regional approach, and we're doing that. They are now, when I left Africa Cities, we established 5 regional centers, network for trainings, for example. We're bringing in North Africa, in Egypt and Morocco. We're bringing in Senegal a network for trainings, a network in South Africa with CSR, a network in Rwanda, and then Central. We're going to find a better way to do that if manufacturing agenda moves forward. That's a way of bringing regional integration into play rather than every single country. That's just for training, capacity building, skills development. So I think I keep on saying that again. I think this is, you're going to hear me severally in several platforms saying that it's an ecosystem approach. An ecosystem approach means everyone has a role to play. If it comes to preclinical trials or clinical trials, we can enroll even just 100 participants in each of the 54. You can play just a role in the clinical trials and then contribute to the ecosystem. You don't have to get a facility, a green facility, to be able to contribute to manufacturing. So it's an ecosystem approach. Even glass vials, you can just do glass vials. Someone can just do rubber to close those vials. That's, again, enzymes. So manufacture doesn't mean a facility. So I think this is where the conversation comes in and is in line with the CEPI Regionalized Vaccine Manufacturing Collaborative. Africa or region going as a block, they have a strong collective advantage of moving this manufacturing ecosystem rather than going in a silo approach. Thank you.
Thank you for the presentation. So as we all know about vaccine hesitancy, I would like to know, don't you think there will be kind of hesitancy from NITAG and MOH about this AVM? And especially because I think, for Benin case, for example, the NITAG was not, they did not know about the AVM going on the continent. So my question will be, what do you think about the potential hesitancy about the AVM in the countries that are not actually producing the vaccine?
No, very good question from this group. I think that's a very important question. We are cognizant that there might be some vaccine hesitancy, disinformation, the made in Africa vaccines, but I can tell you and guarantee you that this conversation has started. I'm part of the RITAC, the WHO RITAC, and this conversation for the 8 vaccines that are currently in the pipeline for 2030, the conversation has started at the RITAC level. And this is to avoid is what you have just said, a very important point, because that's going to drive demands If you have vaccine hesitancy, it means that those commercially viable antigens, they're going to go anywhere. So we need to start that conversation. I usually have a very good example to this question because I was central, as I've said earlier, to the COVID-19 response with Africa CDC. We actually, during COVID, mobilized $2 billion US dollars. I said 2 billion. This is the first time and ever in the history Africa went to the table for negotiation with money. We usually go with beggars. Please, we need 1 million doses. Oh no, we need 5 million doses. This is the first time 2 billion through Afreximbank, Africa put on the table from the African Union to acquire COVID-19 vaccines. But unfortunately, the vaccines were not made available to the continent 6 months down into the pandemic. So what I'm trying to say here, we went for a vaccine, a single dose, and then that vaccines, the largest actually cohort for vaccine effectiveness was in South Africa, where you are currently, the Sisonke clinical trial. So all the problems that we face on the regulatory, and the AU put in resources there to acquire 400 million doses of vaccines. And then there were all regulatory issues. You can go in the history and read what happened to the J&J vaccine. But the continent had only data to back up that vaccine. The Sisonke trial. Why? Because people within the community were involved in that trial. People within the community could defend that they don't have any issues. People within the community were part of the conversation and the research. So my bottom line is that community engagement, risk communication is absolutely important. So now what's happening? We are less than 5% of the clinical trials happening globally are on this beautiful continent. Less than 5%. It means that our community is not involved. Our community doesn't recognize themselves in those products. So we need to start embarking, engaging. There are several flagship sites for clinical trials in Africa. I think the developers should bring those products early enough. Discuss with our own population. We're 1.5 billion people, a huge market. We don't just want the end product. Bring it to us. We are part of it. It should be Africa-led, regionally connected, and globally relevant. Then the vaccine hesitancy word will actually gonna be probably expunged from our grammar on immunization. Thank you, and back to you.
Thank you, Doc. We have one question online. So this question is from Abdul Jalal. So he's saying, in terms of supporting R&D, how does the right model compare to Japan's GHIT approach in practice? He's saying particularly in terms of sustainability, financing, and private sector engagement. And he's also saying, given Africa's limited funding and uneven political commitment, which parts of the right model are usually realistic to adopt now?
Okay, I think again, this is a very interesting question. So I'm primarily I'm a researcher. That's something. So we have been going through this for decades now. And as I've said earlier, there's no, if you want to get to 60%, because there's a political will. I can tell you if we have 55 head of state, I can tell you 60% or 80% even, they know the target of 60% by 2040. But the point is that we haven't done justice as researchers to present a research plan that will take us to 60%. It's someone I was mentioning somewhere, we need to move from the article to the reality. Article number 1, the AU endorsed the plan from the African Union to manufacture 60% by 2040. Those are head of state. But who is taking that plan, that article into reality? That's where the issue, and that's where the question becomes relevant. So we have just started something I think you asked me to answer. We're launching on the sideline of the African Union a program to support R&D. It's called Achieve. Achieve is actually connecting the flagship research institutions across the continent, bringing them together. The best institution in Cape Town, Stellenbosch, whatever you have in South Africa, connecting with the best in Cairo, in Sudan, in Central Africa, in the DRC, where there are outbreaks almost every year, connecting them with all. So we really want to bring them in the African approach, the whole of Africa approach. They are not working together. Each of them are working in silo. We want to break down silo, create network of networks. So that's number one. When we bring all those researchers, the questions on disease prioritization, we need to prioritize together. Is it Mpox? Is it going to be Marburg? Is it going to be chikungunya? Is it going to be dengue? We have 22. We need to prioritize together as the researchers on the continent. The policymakers have already done their part. They have given a list of 22. The researchers have to follow suit with a plan. Now, the most critical bit that you want to hear is funding. We are saying we do not say we don't need partnership. We need partnerships, but funding government to put money on the table. So currently it's a $150 million project. We have received $75 million already for that project. And let me tell you, there are 5 African Union countries that have committed government, each of them $1 million per year for 5 years, means $5 million. This is the first time we're seeing African government putting money into R&D and publicly making it. So we need more countries. If imagine each of those countries, the 55, even just 50%, they put $5 million each. That's a lot of money. You have seen I only need $28 million for cholera vaccines. I only need 25 for typhoid. I only need less than 5 million. So you see, we can do a lot. And all these vaccines for the continent. So it's already happening where we are pushing government to put in money, and some are putting money already. I can give you the names: South Africa, Zambia, Nigeria, and so on. I've already committed and putting money for R&D to move the R&D ecosystem and therefore meet the target, and also sustainability, African-owned, African-led, and then for sustainability moving forward. I think that's happening already. I will invite you on the sideline of the African Union Summit on February 22nd for the launch of that program on R&D, connecting the dot across the continent. Thank you.
Thank you for your good presentation and the questions that have been answered. Mine will take you back onto some questions that we have already discussed, but I just have one question. So for me, I feel like if we have to meet the African targets in terms of regional priority for immunization, one of the key points is to reach the Abuja Declaration. And so we see that most of African countries haven't reached the target that was set in Abuja Declaration, taking the example of 2021, whereas only 2 countries had reached these targets. And also, at the same time, we see that there are so many competing needs in Africa, in public health systems in Africa, which are to some extent due to conflict, outbreak everywhere, politicians who we are sometimes perceived as less accountable. And so that's how we see that most of Ministry of Health programs are donor-based. So my question is, what is being done or what can be done to ensure that these good speech declaration translate into concrete action? Thank you.
No, again, it's back to my point. The head of state, they sit and they take resolutions. For those who have been to the AU, because I happen to be there, I've worked there for almost 10 years, I can tell you they work very hard, our head of state. But between the head of state and implementation, I think something is not right. Because if the good declaration are being made and there's a good tracker and good key performance indicators, and there are people who are following up those targets, I think we can get it done. That's the problem. The good resolutions, but no implementation. We actually wrote a piece in Nature Medicine on that. So we need to start going back to the drawing board. What did we say we're going to do? And what are we actually doing? So the reason being, I think the Abuja declarations, I mentioned the Lusaka agenda. I'm already saying I mentioned also the Accra reset. I think the list is getting too long. But the point is that this is the time where with the ODAs, because we were heavily relying on the ODAs, now with that cut, this is the right time for maybe to address the issue around the Abuja Declaration. You are right, less than 15% of member states have implemented the Abuja Declaration. I think there's now a little bit of mind shift across board for countries that are now looking at their own internal data. I think I'm sure in the next couple of months or so, there's going to be a shift in terms of budget allocated for health, research, and development to drive this agenda on immunization and vaccine manufacturing. Thank you so much. I can see the chair is already looking at me. Thank you. Over to you.
Don't go away yet. We have one last question for you. So we have a question online from Lauren. She's asking, how do we move away from the siloed approach without losing agency or independence in manufacturing?
Yeah, good point. I think this. Well, I mean, let me start by saying, first, countries are sovereign. This is very important. Sovereignty, they are all. I mean, the 55. If they decide today, well, we want to go in silo, there's nothing much. Even the African Union cannot stop them. That's the rule of the game. But we're saying it's better to move together because if you move along, your market alone cannot sustain the current competitiveness globally. Your price is going to be prohibitively expensive for you to compete with the like of the Serum Institute. And we have seen that. We're in the same country we are all in now, where the vaccines were actually open for tenders to international, multinational, and the local vendors couldn't get it because the price was more expensive than what the serum was picking at. So I think, in my views, is that we cannot really stop, but to foster that and break that silo approach, you need to see value into the network. Because what we're doing into what I've said we're going to launch is that we're pairing the best institutions, some in South Africa, some in Senegal, to work together with those that are not in a hope and spoke approach. You're building capacity and capability in areas that you don't have strength. Some can actually be used to support that. And I can give you an example. In preclinical animal studies, you only have 5 facilities on the continent, 5 animal facilities for 55 countries. How dare can you just work alone? So you really have to work as a group, as a team, leverage existing capacity with limited resources to be able to get this target achieved. So again, it really is a call for more solidarity, partnerships, taking into account the whole of Africa approach. Ubuntu, we're in South Africa. Please remember that. So we are all going to work together to make it happen. Thank you.
Thank you. Thank you so much, Doctor. I think I would just like to say I really liked your tone. You put your foot down and you are very blunt with some of the answers that you gave, and that is essentially we can all make plans and goals and whatever, but if there isn't active plans to reach those goals and solutions coming from us as Africans, then there's no way that we'll reach those goals. We'll keep preaching the same thing for the next 100 years. So I don't know if it's an adage or it's just a saying. I don't know what the difference is. What's the difference, Adina? But there's a saying that says African solutions for African problems. I think it also says led by Africans, right? I probably butchered it a bit, but that's the and I really like it. And as I mentioned earlier, I'm an early career researcher or postdoc, and during the funding crisis that we all experienced early this year, 3 of us got together and wrote a paper. And in that paper, we're just reflecting on the impact of the funding cuts on research in African settings. And that saying was one of the things that we really highlighted, the importance of coming up with solutions as Africans and not, as the good doctor said, we cannot be beggars forever. And I think this year has really highlighted the importance of coming up with funding mechanisms within our own settings instead of asking to be spoon-fed all the time. So I hope in the next 5, 10, 15, 20 years, we'll start seeing strategies coming from what we experienced this year coming to fruition. With that said, there's 1 minute between us and lunch. So let me not keep you. And I also just want to say that please be on time for our late afternoon session. We should be here at exactly 2 o'clock because there will be some fun games that you will enjoy. And there's also a prize. So if you want to win something, be here at exactly 2 o'clock. It's a surprise. So thank you so much, everyone, for engaging conversations and to all our speakers for this session. Enjoy lunch. You can leave your bags here, right, Salim? Yeah, you can leave your stuff here. Safe.
Yep. Sorry? Uh, yeah, yeah, yeah. No worries. Are you going to keep the session or do you want to do? You just, yeah, and you just tell them that there's a this on that. Yeah, yeah. We still got 2 minutes. Yeah. Oh, I have to be up early. Control my head. To put it. Down back to fishing. So this is the easy word. So move that. Move that. So application for that. That's kind of like yeah, so it's basically another word for and that's what we'll use for the quick question. For the quick quiz, it can be 10 questions, and then the winner gets. Okay. Okay, welcome back from lunch. Hope you enjoyed it. I think we're about 50%, so we're going to start. It is 2:00. Just to remind, so I'm Tony and I'm the chair for this afternoon. Just to remind you, there's a slight change in the program. So Dr. Farid spoke to us already this morning from the WHO. And Professor Mwenda, his session will be now after lunch. So it's Jason, and then it's Adina, and then it's Petronella, and then it's Lisa, and then you can go home. All right. So we're going to kick off with a warm-up stroke energizer. Prof. Hassi said to me, oh, no, it's not exercises or anything, is it? No, it's not. But Salim's going to tell us all about it. Hello, everybody. Welcome back from lunch. So we did say before we left off that we're going to start. If you're not in the room, you're not in the room, you're losing out on this amazing prize. You want to win it, trust me. But okay. Okay, cool. So if you see on the screen, there is a QR code that you can scan with your phone. If you can't do it on your phone, you can just go to wooclap.com and then fill in that 6 code, that 6-letter code. We're just going to give 2 minutes for people to join. So how it's going to work is there's 10 questions. You have 30 seconds to answer each question. The fastest and most correct person, they will win the prize. Yes, who's the judge? WooClap is the judge. We'll give 1 more minute for people to join. Okay, we'll give another minute accounting for the Wi-Fi. We'll give 1 more minute. I don't think that's how it works. Okay, wait, mine's not even loading. Does everyone need to create an account to sign in? Yeah. Mine also is not asking for a login. No, I'm not logged in. I'm not logged in. Okay, then can I ask
as a backup, go to wooclap.com. So in your phone, type wooclap.com in the browser. And then there at the top, it's going to ask for event code, and then just put that 6-letter code in it. You should raise your hand. Yes, no. If you're on that screen, that's good. If you're on the raise your hand, no voting in progress screen, that's good. So it's asking for some people, it's not asking for others. If you get to the screen, raise your hand, no vote in progress. You're on the right screen. You're on the right screen. You're on the right screen. So how many people are on that screen and how many people are being asked to log in still? Oh, yeah. I had to create an account. Okay. Are most people now on the raise your hand? There's no vote in progress screen? Okay. We can start? Okay, cool. Remember, 30 seconds. Get your head in the game. First question. Which vaccine is recommended for pregnant women to protect their babies from whooping cough? You have 20 seconds left. Five seconds. 3, 2, 1. There's 20 people who are still thinking after 30 seconds. Guys, you have to be quick. You have to be quick. So, what do we think the correct answer is? Shout it out. Tdap. And 35 got correct. Okay, cool. On to the next question. Which disease does the rotavirus vaccine protect against? Remember, you have to be quick and correct. Ten seconds. And time is up. What do we think the correct answer is? Fair, fair. However, 52 of us thought it was and chose the correct answer. So we holding it. We're not changing it for now. Okay, are we ready for the next question? We ready? Go, 30 seconds. Robert Koch used which microorganism and disease it causes to formulate Koch's postulates? Fifteen seconds. And time is up. The correct answer, we'll go with that, Microbacterium tuberculosis. Nice. Okay. Are we ready for the next question? Prepared, remember, quick. What type of vaccine uses a weakened form of the germ? 20 seconds. 5 seconds left. You have our answers locked in? And time is up. The correct answer? Oh, I heard more than one. Yes. Okay, let's move on to the next question. Are we ready? Which disease is known for causing lockjaw? There's some collusion happening here. Good. 5 more seconds. Do people have their answers locked in? Okay. And the correct answer? Tetanus. I wasn't sure about that. So that's why I waited a bit. Okay, cool. Let's go on to the next question. Safe and effective vaccines are commercially available against the following cancer-causing viruses, except, so which is the odd one out? Five seconds. Okay, time is up. What do we think the correct answer is? We don't think. Okay, let's find out then what Woo Club says the correct answer is. Is that correct? So the majority thought it was the Epstein-Barr virus. Does that mean it's correct? Because the most people think so. What do we think? No. Did you guys pick 6? Is that why? Oh. Is anyone super opposed to this being the correct answer? You can come and present. No? Then we're going to accept it as the... Oh, you don't see the bottom. Okay. We'll see. We'll see how badly it affects it. We're going to move on to the next question. True or false? Natural infection is always better than vaccination. Is that enough? True or false? Guys? 1 second. Okay. Hands up. Who thinks the correct answer is true? No one said true. Okay, so no, there should be 0 that said true, correct? Okay, there's 9 of us. There's 9 of us that don't think that. Okay, next question. The following vaccine preventable diseases meet the criteria for eradication, except which vaccine doesn't? Five seconds. Quick. Time is up. And the correct answer? Malaria. Yes, correct. Eh? Do you want to explain why that's the correct answer? You can explain after. We run through this and then you explain after. Okay. I think we only have 2 or 3 more questions and then we're done. Next question. True or false? BCG administered at birth confers lifelong protection against tuberculosis? Okay, time is up. What do people think? False. Some say true. Okay, no, that's not lifelong protection. No. Okay, next question. Are we ready? Remember, you have to be quick and correct. The region where the polio virus multiplies in the body is the, which one? Or all of the above? Five seconds. 3, 2, 1. Time is up. And the correct answer? What's the correct answer? Shout it out. 1. Nice. Good. Okay, next one. Oh, that's the end of it. Okay. So let's see. The top. Sorry, I should have built into that a bit more. That's my apologies. We needed a drum roll and everything. So the one who got the most correct and the fastest, is that online or in here? Come up, sir. Up. Men are faster. Men are faster typers. Huh? That's called, okay, but let's not take away this. Congratulations. Thank you. Congratulations. Okay, thank you for joining us. I hope you're feeling a bit energized and ready for some more knowledge. I'm going to hand it over back to Tony. Cool.
We have to declare a rerun.
We have to
Salim,
declare?
we have to declare a rerun.
Why?
Because some of the questions were ambiguous.
Ambiguous?
Because natural infection can be better than a vaccine. Okay? And in fact...
But the question was always, Greg.
Was it always? It is always.
Oh, okay. Okay.
It depends on your definition of always.
Yeah.
And Koch's postulates, in fact, are not, it's not, the disease wasn't TB, it was anthrax. And ask Tony standing next to you there.
Tony, is that correct? Oh, it is correct.
Okay, so we're going to have a rerun now.
Only joking.
We'll do it tomorrow.
Only joking. Thanks, Greg. So robust debate has always been part of this course. It's always nice to have a good argument. Thank you very much, Salim. I think it has got everybody thinking. So next up is Professor Mwenda, as I said. I think we met him this morning. He's a man with a vast amount of experience at WHO level, having worked at the WHO Afro regional office for many years. How many, Jason? 30 or something? 17. Okay, that's long enough. But he's here today to talk to us about the introduction of new vaccines. And there's nothing which is more important than being able to decide rationally in your country on which new vaccines. We all know that the kids desperately need new vaccines, but which ones? And that's what Jason's going to talk to us about. So welcome, Prof.
Thank you very much, Tony, for that introduction. I think after the energizer and the lunch, we are now ready to continue the conversation that we started in the morning with Greg and Kes and others. And this is the topic for our discussion, which is the introduction of new vaccines, the progress on where we are on some of these vaccines, the public health impact, and also discuss some of the policy considerations. Okay, it's here. Which way do I point? Oops. Okay. Uh, oh, okay. Sorry about that. So this is the outline of the discussion this afternoon. I hope it meets the expectations that we had in the morning, that everyone under the expectation when they came for this vaccinology course. One is to try and recap in terms of the landscape of the vaccines, the progress where we are in terms of the introduction, the policy issues, considerations. I will not go through all the new vaccines. We'll just mention a few, and particularly the ones that there are some major issues with those vaccines, either in terms of introduction or in terms of the schedule of those vaccines. And then the impact of COVID, it was mentioned, also mentioned the impact of the COVID-19, and then the public health impact and key issues. I think Greg mentioned the complexity of the vaccine landscape, where we are since 1974 when the EPI program was established. At that time, there were only 7 vaccines, and mostly these were vaccines for infants. But currently, we have up to 13 vaccines, and the approach has changed slightly from infant and neonate to other target populations, including maternal vaccination, adults, and other target populations. But just to say that I think when you look at this slide, the complexity in terms of the vaccines that we have, administration, the presentation, and not only the target population, but also in terms of number of injections and the impact on the health systems. So you can see it's good news and bad news. The good news is that we can be able to prevent more vaccine preventable diseases using these vaccines, and also be able to scale up these vaccines to be able to drive the maximum benefit. But that's really not happening. So we've seen a change from EPI, what used to be called the Expanded Program on Immunization, to what is now called the Essential Program on Immunization. And the approach, as I've just mentioned, has changed from infants to other, and also in terms of deploying these vaccines using a life course approach. We also have vaccines that are context specific. I think Gray mentioned that these are vaccines that are either regionally used or are used at target population is those at risk. So these are the context specific vaccine preventable diseases. So good news and also bad news at the same time. In the morning, we heard about the new vaccines, but I did not hear anything about the underutilized vaccines. Just to say that I think Greg and also Nikes mentioned that for all the vaccines, they undergo rigorous clinical trials for those vaccines to really undergo what we call the WHO pre-qualification or by other relevant authorities. So really, guidance is extremely important. At the global level, we have what we call the SAGE, or Strategic Advisory Group of Experts on Immunization. This was a group that was established way back in 1999 to provide guidance to WHO in terms of deployment of the vaccines, or give guidance, the strategies, they advise WHO in terms of strategies, ranging from the vaccines to be introduced, the technologies in terms of adjuvants, if these vaccines are used with adjuvants, in terms of the research development and also in terms of delivery of these vaccines and linkages with other public health interventions. Earlier this morning, we talked about cholera not being a single intervention. Rotavirus and others are also good examples that vaccines are not a standalone intervention, but they should be used as part of a comprehensive strategy to combat some of these vaccine preventable diseases. So we should not think about vaccines as a single intervention. We should be thinking about other interventions. If you look at pneumonia, for example, we have a number of vaccines that prevent pneumonia, but we also have other interventions like treatment and others. So you should be thinking broadly rather than a standalone intervention. And when SAGE makes some of these recommendations, it actually makes reference on other interventions as well, and encouraging the countries to think about an approach that is not only vaccines, but other approaches as well. So Greg mentioned about the WHO position paper. Anytime SAGE makes a recommendation, it will issue what we call WHO position paper for that particular vaccine. And if you go to the link, it might not, I don't know that it's clear, but later on you can click on that link and you see WHO position paper on every vaccine that is into EPI. And it gives a background in terms of the disease burden, the epidemiology, and how to use those vaccines. If there are any safety concerns, those will also be highlighted in the WHO position papers. So it's extremely important that those of us who are in the vaccination space regularly look at the position paper and the NITACs, particularly when you're advising the Ministry of Health, you need to be very well informed by looking at the WHO position paper. So it's extremely, extremely important, and that cannot be overemphasized. So I mentioned that in the morning when we were being asked about our expectations, I heard a lot about wanting to learn about new vaccines, but not so much about the underutilized vaccines. So these are slightly different, but sometimes used interchangeably. So the new vaccines are the ones that are not yet introduced into all the national immunization programs following the WHO SAGE recommendation. The underutilized vaccines, they are also recommended by SAGE, but not widely adopted. So when you look at the list of the new vaccines, you will actually see the underutilized vaccines also on that list. Underutilized because they are not optimally used. They are not in all the immunization. And some of these examples are hepatitis B, birth dose, for example, HPV, rotavirus, also MCV, and PCV could actually be in this category. So it's not a very clear distinction. Sometimes, these terminologies are used interchangeably. In terms of the consideration, I think there was some discussion this morning about how do you know which vaccine to introduce, and because sometimes we are faced with 2 or 3 new vaccines or even more, and we have to make a decision as a country which of these vaccines will you introduce first. And some of these decisions are guided by disease burden in your country, and here again emphasizing the need for surveillance so that you can have country data that can guide these decisions. So surveillance is extremely important, or even research that provides some data in terms of what is the disease burden in your own country. And in terms of alignment with other public health priorities, what is the cost effectiveness? What is the operational feasibility of introducing that vaccine into your health system? Because you know that the health system across the country in Africa are not the same. Some health system can be able to take 2 vaccines at the same time. Some other system might not. So these are very important considerations, and also in terms of the affordability of that vaccine. So this is a table. It may not be entirely accurate, but it's just to demonstrate and to show you some of the new vaccines and underutilized vaccines, as mentioned. The rubella conjugate vaccine, pneumococcal conjugate vaccine, rotavirus, yellow fever, hepatitis B, birth dose, typhoid conjugate vaccine, hexavalent. This is the new kid of the block. Those of you who are following the literature, you know that WHO has just made a new recommendation on the use of hexavalent vaccine, and we'll look at that a little bit later. The main 5 conjugate vaccine, the pentavalent for control of meningococcal disease, is also underutilized on new vaccine. We have the HPV, MCV, malaria vaccine also, which many of you mentioned in the morning, and also IPV, particularly the second dose. But I want you to look at the second column also in terms of the introduction. Here again, we're just looking at the 47 countries in the African region, and you can see the status of introduction. So we are far. Some of these we are very close, like PCV, for example. 43 countries out of 47 have introduced. Rotavirus, 41 out of 47. But you can see some of the others, we are really we are lagging behind in terms of introduction. When you look at the coverage, and this is the latest unique on WHO UNICEF coverage data, the latest data, you can see, for example, you just pick a few. PCV, for example, we are only at 65%. Rotavirus, PCV is what, 65? I think it's 63, actually, not 65. And then rotavirus, 65%. And the target, if you look at the regional strategies and the global strategies, the target for the coverage for most of the vaccines is 90% at the national level. So you can see for most of these new vaccines and underutilized vaccines, we are really off track, even though we made some progress in terms of introduction and also improving the coverage. But when you look at the coverage, there's quite a bit of disparity across the different African countries. Some countries have got very strong health systems, like Rwanda, for example. If you look at the coverage of most of vaccines in Rwanda, is just over 90%. You look at other countries like Angola, for example, you find the coverage is very low in the 30s, and mostly the countries in the Central African region. I don't know whether you have anyone from Chad or from Angola, but the coverage in some of these countries is very low. So there's quite a big disparity in terms of the coverage. So this is just to demonstrate using the rotavirus vaccine in terms of the introduction. The introduction of rotavirus vaccine started when? 2009. Which country? Does anyone know? The first country to introduce rotavirus vaccine? No. Ben, I think tomorrow we'll cancel the lunch. Huh? Who said South Africa? Oh, why is Salim? Maybe a present. South Africa, Latif. Yes, South Africa was the first country to introduce rotavirus and also pneumococcal conjugate vaccine. So congratulations to South Africa. And then more recently, look at the trend from 2009. So you can see, which year was that? 2014. Rapid introduction. Many countries, close to 14 countries, introducing rotavirus vaccine in 1 year. So that was quite tremendous. And then there's a slowdown, and we also see the impact of COVID. So this slide basically shows the trend in terms of the introduction. If you look at PCV, it's more or less the same. Others might be slightly different. So where we are in terms of rotavirus introduction is 41 out of 54, which is about 76%. But the key issues for Rota 1 is we still have a few countries that have not introduced. 13 of these countries have not introduced, which is 24%. More recently, we heard from, South Sudan, right? South Sudan introduced rotavirus, PCV, and I think, was it IPV? And Sudan is a country that is facing conflict. We also heard about Somalia, that he also introduced the vaccines at the same time. Chad also introduced Rota, PCV, I think, and measles. They also did the measles campaign at the same time, which is quite impressive, given that these are countries that are facing humanitarian crisis and also conflicts, but they were able to successfully introduce the vaccines at the same time. So these are really good, and multiple introductions are actually common in Africa, which is quite interesting. So there is a lot to learn from introduction, and we have done very well. So this is Rota in terms of the trend and where we are and the issues that I mentioned. Countries that have not introduced, and also the coverage. The other issue with the rotavirus vaccine is the product switch. We have 3 rotavirus vaccines, and we've faced from time to time global shortages, and some of the countries are forced to switch from one product to the other. So we can discuss some of those challenges also. This is to illustrate the impact of the COVID-19 pandemic in terms of the rotavirus vaccine introduction. You can see we really slowed down during the period from 2022, during the pandemic and even the post-pandemic. So we are still struggling for most of these vaccines. Rubella, for example, PCV also, a few introductions, and rotavirus, few introductions. But we've done extremely well in terms of the introduction of IPV and also the malaria vaccine, as you can see on this slide, actually. So there's been post-recovery for most of the countries, but we are still having the impact of COVID in terms of introduction. So the progress has slowed down. But for malaria, we've done well. Last year, 2024, 14 countries introduced. This year, 7 have introduced IPV. There are 21 countries that have introduced the IPV second dose, and HPV also have done well. But apart from that, the other vaccines, we haven't done so well. But I think we are doing well in terms of the introduction. As I mentioned, MCV, we're almost there. Looking at the data for the Afro region, which is 47 countries, 44 have introduced PCV, 43, and then Rota, we have also done well. Apart from these, the others, we are traveling a bit. So there's been a remarkable introduction in terms of the malaria vaccine. Again, just showing again additional information about the COVID impact introduction globally. We dropped from 166 introduction in 2021 to 47. So it's been about 72% decline in terms of the introduction of the new vaccines globally, and we are now below the pre-pandemic baseline. So we've slowed down, and the effect is still being felt, although there are still countries that are introducing. In Afro, about 44% decline in terms of the introduction. So this really demonstrates the impact of the COVID-19. So switching on a little bit to HPV, the initial recommendation for introduction of HPV was 2017. At that time, the target population was girls 9 to 14 years of age, using a two-dose schedule, starting from 9 years old. And more recently, there's been a lot of issues with the global shortage, and there's been some discussions and some research that has been done to see whether the schedule can be changed. And there is now enough data, and 2022, SAGE and WHO looked at the data that was available and actually amended that recommendation of 2017. So there is a new recommendation for HPV, for the use of HPV, starting from 2022. And it's been demonstrated that one dose is as effective as two doses. So most of countries are now using one dose and not two doses. And then there was a slight adjustment in terms of the age, increasing the age a little bit 9 to 20-year-old. And again, countries choose, but within this range. The other important issue that also came up during the recent review of the data was in terms of vaccinating the immunocompromised HIV. Here, the recommendation is to use two doses, and ideally in a multi-age sort of a catch-up approach through the 18-year at introduction. So there's been some adjustments in terms of HPV. So this is, again, some of the key policy issues and also more recent guidance. So to say that once the SAGE makes a recommendation, it doesn't stop there, because the data is continuing to be collected even post-introduction. The research is continuing, and based on that data, SAGE and WHO can make amendments to the original recommendation. And you see that also for PCV and other vaccines. Okay, and then in this recommendation also, there was the issue of vaccinating boys also and on girls, and WHO recommended that because of the global shortage, some countries could do that, vaccinate boys, and there are countries that are vaccinating boys, but you really have to look at the supply issues and really, because the main priority is vaccinating the girls within that age group of 9 to 20 years if we are using one dose schedule. So this is just to show you in terms of the rollout of the one-dose HPV vaccine. Currently, there are 77 countries. So countries that are now using HPV, most of them are actually now using one dose and not two doses. So you can see where we are in terms of HPV single dose deployment. There are some studies that have been done looking at the impact of HPV, and I couldn't find any study in Africa, maybe South Africa, but the data is quite scanty in terms of the impact of HPV. and mainly because of the approach to monitor the impact. We need to have very well-kept cancer registries to be able to look at the impact. So there are a few countries. England is one of them, Sweden, Denmark, and Scotland. I've done some studies to look at the impact of HPV in terms of reducing cervical cancer. And you can see this is, I think, data from England. We showed 80% reduction in terms of cancer using their cancer registries. And again, it was sort of age specific for the ages 12 to 13. This is where there was a reduction of 87%. And the older ages, 14 to 16 years, the reduction was 62%, and then 32%. So it is important that HPV is given at early age as early as possible, according to the WHO recommendation or stage recommendation of 9 to 20 years. But the earlier the better in terms of vaccination. Just looking at PCV again, PCV is quite interesting also because there have been a lot of issues with PCV, and we will come back. But first of all, just to demonstrate in terms of the trend, sort of mirrors the introduction of rotavirus vaccine. Again, which country was the first one to introduce PCV? This side of the room? No? Not lunch tomorrow. South Africa, again, was the first one to introduce. So you can see where we are. So we've also made quite a good progress in terms of PCV introduction. 80% of the countries have introduced. So we still have a few countries. And when you look at those countries that are not introduced are the same ones, rotavirus vaccine and PCV, they are basically the same countries that are not introduced, and there are a lot of challenges. I don't know whether there are some colleagues from those countries. Who can name one or two countries that has not introduced PCV and rota? It wasn't Egypt. Yes, Egypt. Why? Vaccine cost. Because Egypt is not Gavi eligible, so they have to buy the vaccine. And they have also been looking at the possibility of manufacturing a PCV in the country, so that has delayed. Egypt is one of them. Then Gabon, we also have Equatorial Guinea and others that have not introduced these vaccines. And normally they're the same country. Sorry? Sorry, I can't. I think your neighbor is from Gavi.
They too rich.
So neighbor, why is Egypt not Gavi eligible? They are rich. Is it true?
Just to tell her that there's a threshold level above
Right.
which you're not eligible. So for 2026, it's just over $2,000 per person, the GNI.
Right. So that is the basis, mainly the GNI. So Gavi looks at the GNI. This is the World Bank data on how rich the country is. So if you are above a certain threshold, I can't remember, Greg just mentioned, then it means you are not Gavi eligible. Same thing with South Africa, Gabon, and other few. Yes, please.
Hello. Regarding Tunisia, because it's not did not introduce rotavirus vaccine. Actually, the NITAG assessed the situation and did not recommend it to MOH because it's not relevant to context. So an assessment has been conducted by the NITAG, and it's stated that it's not a priority for the country.
Oh, interesting.
Interesting.
Very, very interesting. Latif?
Yeah, I had a similar comment that if we're saying the reason why Egypt has not introduced is because of high cost, because they're not Gavi eligible, isn't that system a bit counterintuitive because we're categorizing a country as too rich to be in Gavi, but they have not introduced because it is high cost for them. So they're now like stuck in between where they can't afford it, but they're also not eligible for Gavi. Or is it a burden issue that it is low priority in their setting, that they don't have much pneumococcal invasive pneumococcal disease?
Interesting discussion. Maybe we should wait for the Gavi presentation. Is it tomorrow? Is a Gavi presentation? So you can be able to answer that for us. But there are many issues in terms of the vaccine introduction. Of course, cost is one of them. the health system and the prioritization, because the country may prioritize vaccine over the other. So could be. But from what I heard, because there was a meeting I attended, I think it was sometimes in April, where there was somebody from the Minister of Health, Egypt, where he said the reason why Egypt does not introduce it because of the cost of the vaccine. For Tunisia, interesting discussion, that one. Maybe we should park it somewhere because we need to go through the presentation. But I really appreciate these comments.
And maybe we should just stop the questions and you finish your presentation,
yeah, sure.
Jason, and we can have the questions afterwards. Oh, okay.
Oh, I only have 15 minutes, please. I need to. Okay, so just moving on to PCV, I mentioned some of the issues. One of the issues is the low coverage, so that's an issue that we are dealing with. We need to scale up the coverage, the introduction, and also the coverage. The other issue I wanted to mention is in terms of the schedule. If you look at the WHO position paper in terms of PCV recommendation, the schedule was 3+0. In other words, 3 doses without any booster, or 2+1. There's been a lot of issues, and some countries have been asking, and also because of the global shortages, there's been a lot of discussions on whether these recommendations should stay, and WHO formed a special task force to actually look at the schedule, look at the data that is available in terms of the reduction of the disease burden. But for now, the option are 3+0 or 2+1. And last year, WHO, as I mentioned, convened a task force to look at the data that is available from a number of countries where the data is available, and still re-emphasizes the 3+0 or 2+1 schedule, which is still recommended. But there are countries that have actually switched. Like I think South Africa has already switched to 2+1, right? South Africa is using 2+1 for PCV. Mozambique and also Burkina Faso has also changed the schedule. And there are 3 products now. There is PCV10 from GSK, there is PCV13 from Pfizer, and there is PCV10 from Pneumocell. So this is from developing manufacturing from India. The cost is different, and some countries are also changing the product to the cheaper one, particularly those countries that have graduated from Gavi. There are some who have switched, like Kenya has switched to PCV10 Pneumocell from, I think, Serum Institute of India. So in terms of the schedule, as I mentioned, we're still using 3+0, 2+1, but the task force also looked at the possibility of 1+1, because there are countries like in Europe where they have now changed the schedule to 1+1, and then the data is still being collected, and WHO said those countries that they have strong systems, you can change from either 2+1 or 3+0 to 1+1. So the issue of the schedule is still up in the air in discussions, but WHO has recently, I think it was September last year, that WHO gave the guidance in terms of the schedule. So you can choose which one depending on, and if you look at the position paper, it stipulates what can actually guide you on what will be the schedule, apart from, of course, the cost in terms of the product switch. So, and this is trying to reduce in terms of the number of doses. So 1+1 could also be used. WHO also emphasized the need for very strong surveillance to be able to monitor not only the impact on the disease burden, but also in terms of the serotype replacement. So you need very good surveillance to be able to monitor the impact. So very quickly on RSV is also a hot topic right now, and this is just a slide to show the burden. This was a paper that was published 2022 showing the burden in terms of the episodes of low acute respiratory infections in children. You can see in terms of the episodes that 3 million. Globally, 3.6 hospitalizations and close to 100,000 deaths per year, mainly in children under 6. So very high burden. And as you can see on this slide, the total mortality is quite high for RSV infections. Looking at the hospitalizations due to RSV, you can see Seattle, which is southeastern region, the 23%, 22% East Mediterranean or EMRO, and Africa or Afro is 19%. So there is quite a huge burden in terms of the RSV. Mortality is also high, particularly in Africa. So there is a strong justification and rationale for introduction of the RSV. So just to say recently, actually I think it was May this year, there was a WHO recommendation on the use of RSV. So there are two available vaccines right now. One is for maternal vaccination, and I think Greg mentioned about the maternal vaccination. RSV is one of them, which is given during the third trimester pregnancy. There is also the monoclonal antibody, and I think there are a few countries where there is authorization. Yes, this is a slide, I included it. So, so the recommendation is quite recent, but there are countries in Africa. Which countries are these that have market authorization for RSV? South Africa, Ghana, Egypt. Yes, at least Egypt for RSV. You tell us how you made the decision, but congratulations, because when you look at the burden is quite high, especially in neonates under 6 months kids. So I think it's a vaccine of really high priority. In terms of the vaccine in pipeline, I will not go through this. I think Nick has mentioned and also Greg mentioned, but just to say that there is also a very rich pipeline of new vaccines. So as we think about the ones that are already pre-qualified, we should also be thinking about some of these vaccines in the pipeline, because they are also quite important. And these are some of them. I will not go through this because I think we have discussed this later. The hexavalent, the new kid on the block. So it's basically adding the IPV. So you can see diphtheria, tetanus, or cell hepatitis. I think, was it Salim during the Energizer talked about pertussis and cellular hepatitis, but for hexavalent, it is wholesale hepatitis that we included. And then we have the Haemophilus influenzae type B, the hepatitis B, and the IPV. So there's a new recommendation on the use, and there is also Gavi, hopefully for the Gavi presentation. You also mentioned the support that is available for countries that want to switch from DTP to hexavalent. So there is also support from Gavi for switching, and the vaccine has become now available, I think, since late last year. It's available. I'm not quite sure about the global supply, whether you meet all the requirements and the demand that is there, but there is a WHO recommendation to switch if the countries want to switch to hexavalent, which is also quite interesting. And again, it reduces. I think these are some of the benefits of the hexavalent vaccine in terms of reducing the number of injections, reducing the cost. 10 minutes left. IPV, hopefully increasing the IPV coverage and also facilitating the integration. So these are some of the benefits. And if you look at the hexavalent position paper, you can find the details. So just to summarize, in terms of public health impact of vaccines, I think Nick has mentioned and also Greg mentioned, we know that these vaccines work and they have a huge public health impact and benefit in terms of the disease burden, which is well documented for some of these vaccines where the surveillance or research is being conducted to look at the effectiveness and also the impact of these vaccines. There's a lot of data on rotavirus vaccine within the African continent, PCV and also HPV. I think Greg mentioned in terms of the return on investment. This was a study that was done, I think, around about 2020, looking at the return on investment, where they shown that for the period 2011 to 2022, for every dollar that was invested, you get $16 return on investment. When you look at the additional societal benefit, the return on investment is even higher, up to 44%. I think Nick has mentioned a more recent study that they did, showing that for every dollar you invest, you get about $55 return on investment. So these vaccines have got major public health impact, not only on the disease burden, but in terms of also the returns on investment. And there are a number of studies now, health economists who are doing some studies to really demonstrate the impact of vaccines. So just to summarize, to say that there is a huge public benefit of vaccines and the return on investment, which has been well documented. It's available in the literature. The potential impact of this vaccine in the African continent, even though there's been, but it's not fully realized because the coverage is low and there are countries that have not introduced these vaccines. And this is where the NITACs and training like this one, vaccinology course, where we really understand about these vaccines can be quite useful. So I think, and there are more vaccines that are underway. I think I'll stop here for now. Thank you very much for your attention.
Prof, and finished a little bit before time. We've got about 10 or 15 minutes for questions. Dina's doing sign language to me. Oh. Yeah, we're a bit short of mics. I'll just shout. Okay. So we've got some time for questions. I wanted maybe to start off. You talked a little bit about prioritization. You want to say anything about the NVI PST tool, the new tool that's being rolled out in partnership with WHO and the University of Geneva to help countries to prioritize? So as I said, we've got all these candidate vaccines that we would love to include in our programs. We can't afford them all. We don't have the other resources to make them happen. How do you make an objective, evidence-based decision about which one to introduce first? And so there's this tool that they've developed, which they're busy, and we're very much involved with that at NISH, rolling out the training for that. So I don't know if you wanted to say anything about that.
You've actually answered the question. So just to say that I think it's a very powerful tool because, as you see, there are a number of vaccines and the countries are faced with the decision which of these to introduce. And what happens is you have various data that you need to put in there, the disease burden, some information about the cost of the vaccine in terms of the strength of the health system. And these two help you in terms of the prioritization. I don't know whether there is any country that has used these two, because it's available. It's a free tool. It's open source kind of a tool that you can use to help you in terms of prioritizing. There's also a tool actually that also helps in terms of optimizing the vaccine. So there are a number of tools that are available, open source tools that can help in terms of not only prioritizing in terms of vaccines, but also optimizing the vaccines in terms of the schedule, for example.
You might have used the previous tool was called Capacity, I think. Is that right? Yeah. So NVI stands for New Vaccine Introduction. PST stands for Prioritization and Sequencing Tool. Is that correct? And Ramonda, wave your hands. Okay, so she's kind of organizing the niche input on that. So if you've got questions about it, she can give you all the source material and refer you to the websites. All right. So I just wanted to mention that. Are there any online questions first? Where's Tsepi? Nothing? All right. Anything from here? Sir, have we got a mic here? Yeah.
Here we go. Thank you, Professor, for the presentation. I have a question. I don't know if there are data about this, but every new vaccine that is introduced comes with a cost for the routine vaccination. So I don't know how is your take on this? Like we've noticed that with the COVID vaccination, the positive impact that we had with the routine vaccination had a problem after that. And when the HPV came, also we've noticed the same trend. So do you have any information about this effect? Thank you.
Yeah, that's a very important question. I don't have the figures, but I know there are studies that have been done, because when you talk about the cost of vaccine, there is a cost for procurement of that vaccine. For example, PCV is going for how much now? Is it $6 per dose or something? But then, in addition to the procurement, there is also the operation cost for deployment of the vaccine. There is the maintenance of the cold chain or expansion of the cold chain to be able to accommodate that vaccine in the EPI. So it's a very important question. And there are some, I don't know whether anyone has some figures, Greg, whether you have some figures, but yes, the studies have been done to actually be able to determine what is the operation cost of deploying that vaccine to actually get the vaccine successfully into the EPI.
Thanks, Prof. Chipis was telling me there's 2 online questions. Where's Chippy? There we go.
Oh, okay. So the first question is from Nada. She's asking why South Sudan is not introducing PCV. Do you know why?
South Sudan has just introduced.
They've just introduced.
Yes, yes.
Okay, Nada, someone from South Sudan is saying they have introduced it.
They actually introduced 3 vaccines simultaneously. Rotavirus at PCV, second dose of measles, MCV2.
Right, okay. And then there's a comment and a question from Abdul. He's saying, given the complexities of introducing new vaccines into immunization schedules, even developed countries that can afford them are looking into innovative ways. And he's giving an example of Gates. I guess this is the Gates Foundation investing a lot in trying to develop combination vaccines. So his question is, what are some of the approaches that could apply in the African context?
Well, just to say that I think it's a very good idea in terms of combination of vaccines, and there's a lot of effort towards developing combination vaccine. Rotavirus, for example, there's some efforts to develop a combination vaccine for rotavirus, norovirus, I think, and also adenovirus. It's at the developmental stage. It's not available yet, but it's a very good idea because one of the issues that the healthcare workers are faced with is having to give multiple injections for vaccines. So it's an area that is developing. Watch the space. We'll probably have more of these combination vaccines, and I think it's a way to go. Greg, you want to comment?
You say there's a lot of work going on with respect to combination vaccines. I mean, as an example, countries where they are using COVID vaccine and influenza, work is happening. And in fact, I think there may be one licensed combination COVID and influenza vaccine, which is quite a difficult construct. But just while I have the floor, the issue of hexavalent vaccines, I mean, that's a good model in terms of the combination vaccines, that we've now have a vaccine that has that protects against 6 diseases. Just remember that there are different kinds of hexavalent vaccines. The one that we use mainly in Africa is the whole cell pertussis 6-valent vaccines. Some of the countries in Africa, like South Africa, Mauritius, have in the past introduced a hexavalent vaccine that has an inactivated whole pertussis component. So just be careful. Gavi's gone for the whole cell 6-valent vaccine, which works very well, and it's much cheaper than the acellular 6-cell.
Yeah, thank you. The other thing also is the concern about vaccine wastage. I think we talked about combination, and then there's also the concern about vaccine wastage, especially in my country. There is some vaccine wastage is concern, so that the direction is to have vaccine vials that are containing less doses. This one can work, but also we have to talk about what you said, the vaccine, the fridge capacity, because when you decrease the number of doses in a vial, you are increasing the space that they need to take. And in countries that are like mine, you don't have many vaccine stores at the county level or at the health facility level where the fridge's capacity is very small. So you need more doses in a vial so that they can sustain the space that we have. So I just wonder. Thank you.
Yeah, good.
Thanks very much for the question. You're a pharmacist, eh? No? You're a medical doctor. Okay. No, thanks. Jason?
No, I fully agree. I think the presentation is extremely important because the presentation also has an impact on the cold storage that you require. You look at the rotavirus vaccine, for example, you know, the 3 vaccines that are pre-qualified, they have different presentations. Some of them, there's one that is lyophilized, then you have the 5 dose, you have the 3 dose. So presentation is also extremely important. And this 2 dose vial.
Malaria vaccine was introduced 1 dose vial,
Right.
which work, but it's trained on the capacity of the cold chain as well. And we have a lot of, they overstocked the cold chain. It caused vaccine wastages due to VVM. That is stage 3 or 4. So it comes in like we
Right.
need to, yeah.
A lot of balancing in terms of the considerations for deployment of the vaccine in the program.
Thanks. We had a question here.
Yeah, thank you. My name is Mary. I work with Gavi. So I just wanted to contribute to the Egypt conversation. So Egypt is actually Gavi eligible. Yeah, so in Gavi, there's the core Gavi countries, and then we also have the middle income countries, which Egypt is part of. So just wanted to clarify that Egypt is very, very Gavi eligible. It's just that for countries in that bucket, they pay more co-financing, and the procurement of doses that Gavi does is way lower than the core Gavi countries. So we have Gavi 57, and we have some other middle income countries, which falls under the middle income category. And from what I know, the team is already talking to Egypt, and middle income countries are eligible to be supported for HPV, IPV, and PCV. And currently PCV is like the most prioritized in Egypt. So those conversations are ongoing. I just wanted to add to it that Egypt is very Gavi eligible. Thank you.
Thanks very much. I think that's very useful. Any more questions? Are there any more online questions? Where's JP? No, no. Anybody else? You got one there? Okay, there we go.
Oh, so this is from Yawa. They're saying, what communication strategy can you give us to facilitate public acceptance of the introduction of a new vaccine in the context of the influence of social networks, I guess social media?
Well, thank you. I don't know whether we have communication experts here in terms of, was there a presentation on vaccine confidence in the program? I think there is. There will be I think there will be a presentation. But I think it's a very important issue in terms of the vaccine hesitancy. Post-COVID, we have seen a lot of issues with the vaccine hesitancy, mainly because of COVID. That was there, but I think much more right now in terms of the pandemics and all sorts of issues about misinformation about the vaccine. So, yeah, but I think the country needs to have a good communication strategy to ensure that they can be able to counter the vaccine hesitancy. But I think the key thing is to have the data. It's not good enough to say the vaccine is safe without the data, and that is why there is the pharmacovigilance system in most of the countries to monitor the safety of the vaccine. In the event that there is any signal, then action can be taken. And post-marketing surveillance to be able to make sure that there is data. So when you are developing your communication strategy, you are not just saying the vaccine is safe, but you need to have the data on the safety profile of the vaccine, and also in terms of the public health benefit, the return on investment on that vaccine, to be able to justify the investment on the introduction of a specific vaccine.
We've got a session later in the week with Adele. You met Adele last night, but later he's a communications expert, and I'm sure she'll cover something on social media. But we don't have time to do it now, but it would be very interesting to hear from all the different perspectives of the countries represented here, what is your health department's and your government's attitude to social media? Because many of us dislike it intensely, myself included, and we try to pretend that it doesn't exist. And yet that's how people communicate nowadays. So we have to engage. It's not an if, it is a must. You have to engage on social media. But how do we do it, and what is the government's stance? But we can't go into, there's a question down here from my boss.
Thanks, Tony. Thanks, Jason.
My question is on the delay from pre-qualification of the vaccine by WHO to introduction in Africa. So PCV, for example, since it was pre-qualified in early 2000, we know high-income countries introduced that immediately. But 25 still on. We're talking about Egypt, and maybe 20 years after, we were talking about South Sudan, Chad, and a few countries. And COVID came, we saw that it took very short time from licensure to introduction, but that was in unique circumstances. Now you've talked about RSV, and it was, I think, pre-qualified last year, and we can see some signs that 3 African countries are preparing to introduce. Are you seeing some change of trend that we're not going to be waiting for 10 years, 20 years, and we're going to be rapidly introducing the vaccine after licensure? And what do you think are the factors that could help us not wait that long? Thank you.
Yeah, thank you. Current question. I think we've seen some changes in terms of the timeline of introduction in Africa. If you look at PCV, for example, before that, I think funding is one issue. Not the COVID. The COVID was a special case. I don't want to go into COVID. But I think if you look at malaria vaccine, for example, the deployment of that vaccine, it's quite rapid. So there are many issues. Cost is one of them. The supply issues is another one, because sometimes, you are ready to introduce, and then when you're just about ready, you're told, the vaccine is no longer available because of the global shortages. So there are a number of factors, but I think cost and the supply situation are two of the most important ones. And then, but the cost mainly. If you look at, for example, countries that have not introduced PCV, is either the conflict, the cost of the vaccine, especially the countries in Africa that are not Gavi eligible, they always struggle to introduce the Gabon, for example, Gabon, Equatorial Guinea, some of these, Cape Verde also, I think they also struggle to introduce the vaccine, and mainly because of the cost. Tunisia, I thought it was a cost, but I asked about the prioritization. So there are a number of factors. The cold chain expansion also, because sometimes you want to introduce, but you realize that your cold chain facility cannot be able to accommodate a new vaccine. So there are multiple factors. But there's been, I think, a sort of a positive trend in terms of the timeline for introduction. When you compare the developed countries or the high-income countries and the low-income countries, there's been, I think, an improvement in terms of that delay that you mentioned.
Okay, got time for one last burning question, eh?
Yeah, you spoke about the malaria vaccines, the RTSS and the R21. So I just wanted to understand from a Gavi perspective or from a WHO perspective, what would be the criteria for countries if they will be allowed to choose which vaccines they're going to introduce going forward now that we have 2 on the market?
We have colleagues from Gavi, but I think it's mainly the availability. It's mainly the availability. RTSS was, I think, the first one to be pre-qualified. Immediately it was pre-qualified. There were a number of countries that wanted to introduce, and for some, I think it was Mozambique that had to wait for some time for the supply to improve. So I think it's mainly the availability of the vaccine. But I think with the 2 vaccines now, that has improved a little bit.
Okay, thank you.
Thanks so much. Prof. Mwenda is here the whole week, eh? Yeah, you're with us the whole week. And as I said, he has a vast amount of experience. So please do engage with him over lunch and tea and pick his brain. Yeah. All right. Thanks very much, Prof. Jason. Next up, we have Edina. So she was described last night as the queen of health systems. There she is. And this next topic is very much a health systems topic. So it's talking about resilience and innovation, building stronger programs in Africa's dynamic landscape. So welcome, Medina. I told her last night that For some reason, I'd never realized that she was from Ghana. And I always said, Kofi Annan, who was retired some years ago, but I always thought he speaks the best English in the world. He just had that impeccable way of delivering. And Adina's like it as well. I listened last night. I couldn't detect one grammatical error. So welcome, Adina.
Thank you very much, Tony. And with that, you've set me up because I was busy being your Minister of Entertainment last night at the gala dinner. I'll have to admit that I didn't have enough time to look at these slides. So this is actually going to be group work. It's going to be a collaboration between you and I. I have volunteered our very first co-speaker who has the microphone. And what's going to happen is the microphone is going to go around and we're basically just going to have a conversation about this particular topic. Don't be scared. It's not a big deal. It's basically that we want to touch on some of the concepts that have been shared throughout the course of this day. We are talking about the immunization landscape in the African context. We've had several presentations that have basically set it up for us in terms of what the realities really are. We have excellent vaccines. They're not always reaching the people that need to receive the vaccines. So how do we go about changing the status quo and improving the health and well-being of our populations? So my talk is on resilience and innovation. It's supposed to be some kind of turn from, the grim conversations we're having about conflict and all of that. I don't know if I'll win at that, but basically I want to talk about building stronger immunization programs in Africa's dynamic landscape. So the very first question. What is the first thing that comes to your mind, one word, when you hear the word resilience? Yes, you're the one with the mic. Just one word that comes to mind when you hear the word resilience. And to our online colleagues, I can't see your comments, but please do share your comments with the rest of the team. So the first word.
Perseverance.
Perseverance, that's a good one. Next. Oh, you can just pass from next person to next. Sorry.
Sustainable.
Sustainable, that's a good word.
Continuous strength.
Sorry?
Continuous strength.
Continuous strength. Fatima says overcoming.
Not giving up.
Not giving up.
Boldness.
Boldness. I like that one. Adaptability. That's a very good one. Preparedness. Excellent. Those are great suggestions. So it sounds, those are all very positive words. Can resilience struggle? You can't be resilient if there's nothing negative happening to you. So there's an element of struggle, okay?
I'd say no pain, no gain.
No pain, no gain. So we're hearing some very positive words. We're hearing some negative ones, as not negative, but basically saying usually it's in the context of a problem.
Okay, and there's a couple of online suggestions here. Adaptation, recovery. Yeah, that's it.
Adaptation and recovery. All right, good point. So I think with what Latif was also mentioning is there's that element of struggle, but also can you be resilient forever? Is it sustainable? So that's a very good point. So perhaps let's look at resilience in the context of a scenario. Okay, so let me paint the picture for you. Let's look at it in the context of conflict and displacement. And basically it's about reaching underserved migrant communities. And Dr. Farid earlier this morning, just painted a real life picture for us in terms of what happens in conflict settings. So here's an example. We have a district, and this district has experienced ongoing armed conflict for some time now. Health facilities have been decimated, and many health workers have relocated, which makes sense. It's for their safety. So there are also a large number of families that are now displaced and they're moving across borders trying to find safety. In the midst of all of this, we're seeing reduced vaccine coverage and also an increase in periodic outbreaks. So what would resilience look like in this scenario in terms of sustaining vaccine delivery? Who has the microphone? There's a hand here.
Thank you. I'm thinking of having kind of mobile clinics
Mobile
to
clinics.
deliver some basic health services.
Okay.
Yeah.
All right. That's a very good suggestion. Yes, in the back behind you, Greg.
If we cannot afford to provide health services at fixed locations, so we need to move to the community, either he said for the mobile clinics or to use the community health workers.
So
themselves.
using leveraging community health workers to bring services closer to the community.
Yeah,
because they cannot come to the fixed health
Yeah.
posts any longer.
If I can share one real scenario we had in Sudan,
Yes.
because just after the war, this is exactly what happened. And the healthcare workers, they moved, from the center of the country to all other parts. So the malaria services were disrupted. So we thought about finding a solution. So we thought about using, the displaced healthcare workers in the States. And then we contacted them. So they moved to their homelands and we used them. We brought them and trained them, and they worked in the hospital and with the community.
Thank you so much for sharing that. So that's a real life example of a resilient immunization system. Yes.
Yeah. And another thing that I think also the infrastructure, if we can fix the infrastructure, because those mobile transport cannot be able to reach these hard to reach areas if they are unable to cross some of the rivers, the roads that are damaged. So infrastructure also contribute to resilience.
Okay. So you're thinking the mobile clinics are a short-term intervention, but then long-term, at some point when things calm down, we need to reinstate the infrastructure to make sure that we can sustainably deliver immunization services. Yes.
Yes, I think when you're looking at resilience, it also has to do with the actual people in the community.
Okay.
So, for example, when you in a scenario like this where you are prioritizing so many things, trying to avoid danger in so many ways, well, how do you look at vaccines, which is trying to prevent a disease that you don't have already? So now, when it comes to programs for children, for example, are mothers going to prioritize taking their kids or to whatever facilities available to get vaccinations when they're worried about food and safety and things like that? And I'm not sure as this in this type of setting what our impact can be on things like that when once the medication or once the vaccines are in the communities. How do we look after the other needs of the communities so that they're able to access them?
Okay. So thinking comprehensively, you can't bring vaccines to people that are struggling with malnourishment and all of that. So looking at it comprehensively and delivering other needs and being a responsive system.
Yeah. Yeah, I was going to say that.
Sorry.
Yeah, oh, sorry. Yeah, I was going to say that with this example that you've given, you've clearly said the families are now displaced.
Correct.
They're moving across borders. The health workers have also relocated. So the response of doing mobile clinics sounds like something you would do now at a hard to reach area, not somewhere like Gaza or that picture you've put up there. So I don't think that would work.
What would work?
So resilience would be them staying alive.
Who?
The people, the community staying alive, because they need to stay alive before they can be vaccinated.
Okay.
Yeah.
Yeah.
That would be like on in their context.
Okay. Good point raised.
So I just wanted to share my country's experience. So we have a WHO initiative, AMTs, Emergency Medical Teams. So every country, it can be governmental or non-governmental. These are medical teams that are supposed to go to disaster areas, which are self-sufficient and that won't take anything from the local infrastructure, but they go in there and then they support the health system there. So I think Senegal is the only African country to have a WHO classified AMT team. Hopefully Ethiopia is working to be the second African country to have a WHO classified AMT team. So these are self-sufficient medical teams that provide essential health services to communities in disaster.
Disaster areas. Thank you for sharing that. So I'll take two more. There'll be other opportunities. There's one at the back, and then we'll come to you, Fatima.
All right, I wanted to say most organizations are required to adopt the business continuity plan. So business continuity plan, it talks to the preparedness. In cases of these, what you would have done in putting place measures to say, if this happens, how are you going to access the communities, how are you going to access the gatekeepers in the communities and things like that. So I think it's preparedness.
Preparedness and putting together a structured plan is what I'm hearing. Okay. One more point here.
Yeah. I think also in such a setting, soft core issues.
Sorry, software?
Soft core issues, trust,
Okay.
communication, safety, leadership, community buy-in, because there's a lot of emotion even in living where people are. So where is proactivity in there? So part of resilience is addressing these issues because of just what's happening in this setting.
Sometimes the broken trust is not only in the health system, it's actually trust broken with a political system. And so there are a lot of concerns already at that point. So thank you so much for engaging on this. What I like about this is I'm hearing voices I haven't heard throughout the course of today. There we go. Is that better? Yeah. Okay. So next, innovation. What's the first thing that comes to mind when you hear the word innovation? New ideas? Hillary? Creativity? Thinking out of the box? Thank you, Fatima.
Expensive.
Expensive money? Thank you. Not the biovac table.
Throwing the box away.
Throwing the box away. Okay. I've never heard that one. Thank you, Olainka.
Since we're doing metaphors, painting outside the lines.
Painting outside the lines. Less labor intensive.
Online are saying reframing of old ideas, novel new ideas.
Novel new ideas. Thank you. Those are really good suggestions. So these two words, resilience and innovation, do you think they resonate with our African immunization programs? I'm seeing some no's and I'm seeing some yeses. We're divided, but let's move on. Let's think about innovation in the case of another scenario. So I'm glad I was hearing some very creative responses around innovation. Sometimes when we think about innovation, we're thinking technology and data and AI. But sometimes we need innovation in trust building and demand generation. So let's look at this case where we have an outbreak response campaign taking place in a particular setting. And as the outbreak response is happening, there are rumors that are starting to spread on social media. And some people are starting to say, oh, the vaccine they're using in this response strategy is unsafe. And people naturally are starting to get concerned. So uptake of the vaccine drops rapidly, and healthcare workers who are leading this outbreak response are reporting that community members are confused and they are fearful. They are not necessarily hesitant. They are not necessarily opposed to the vaccine. They're just not sure who to listen to and who to trust. So in this context, in this scenario, what kinds of innovative strategies would you suggest that we implement to, I guess, buy back trust?
So working with community influencers, which are usually overlooked.
Okay.
We have some, I don't know about other countries, but in my country, we have some strong community influencers like the chiefs, those traditional healers, which in some countries maybe they don't have any weight, but in some localities they are very strong, and they look like those doctors at the community level. The women group, the youth groups that are being used, the religious leaders, who, if they oppose to something, they have congregation that are bigger than what you can think. So if they oppose to something that you are doing,
Yeah.
the community will follow. And they are usually missed in all the project cycle from the beginning, from introduction to everything. So if you overlook those groups and you come in as an outsider, the community will not trust. You have to come through their system that they trust, either religiously, traditionally, whatever. So you work with them even though you don't think it will work.
Yeah.
And how strong they are, but you have to work. In my country, we work with witch doctors, we work with traditional healers. We work with them because through them we get people to come and trust us.
Okay.
So this is very important. I think I agree with him. Building trust is important.
All right. Thank you for sharing that. Can I take one comment from the back? There was a hand there, and then we'll come back. Ah, okay.
Also, we use the same as Fatima mentioned. We do peer-to-peer community dialogues and community engagement. We use the community leaders, community traditionals, all that stuff.
Okay. Thank you for that. Can we take two comments from here and we come back to you?
Yeah, I had a similar comment in saying that we have to use people that's embedded within the communities already, because the relationship and the trust is already there. It's not something that's newly built, you know, so we're not coming in from the outside and trying to form relationships now that it's already uncertain and there's already mistrust. And if you use the voices of the people that's already there, that often speaks louder. And then the other thing is also that sometimes we come with a westernized approach where we come leading with the data in an environment that's already filled with emotion, and people don't always respond to just, you know, like the intellectual part of it and seeing the data, but they need that human connection and that voice that they trust to, you know, inform or help them make a decision. And they also need to kind of decide that they've heard all the information before making the decision and it's not just forced upon them.
Brilliant. Thank you for that.
Okay, so I'm going to talk on data. And for me, the innovation, one of the greatest innovations will be active listening, community listening, and just trying to understand each context. There's always that thing of community leaders, traditional leaders, and it gets to a point whereby those are also exhausted. People want to be the ones to be the decision makers in their own interest. And how do we bring in the social and behavioral context to this? This could be channels, but at some point in time, those channels will be exhausted. People want agency. And to get agency and build trust back is just active listening, observation of what's happening in that context. And simple observation could be like the chemist, you know, people forget those core structures also within the communities, apart from the traditional leaders, you know, the youth, but, you know, where services are also happening, as some people have mentioned, the witch doctors, whatever, traditional healers, it's also just observing what are they doing right that can also inform the health system better in terms of human-to-human interactions. It's also key in this, but active listening, really listening to understand the context, the situation would always help us. And data is also important to drive your communication and the message that needs to go out. We need to contextualize message and communication.
Thank you, Olainka. Can I? Yes.
I just want to add that building innovation that can rebuild confidence depends also on the community context and belief. So basically, we had the same experience back in my country during the COVID vaccination. And what helped us?
Your country is?
Mauritania.
Mauritania.
So what helped us was the religious leaders. So because we have a very strong belief on religious belief, so they are the one who pushed people during like the Friday prayer. They pushed people to get vaccinated. So we don't have many influencers, but the religious leaders, they were like the innovative solution during the COVID vaccination campaign.
Thank you. Thank you for that. Okay.
Okay. I just want to share Benin experience, especially on the HPV vaccine. So we previously, between 2016 and 2020, introduced a pilot phase of the HPV vaccine. So now, this month, we are about to introduce the nationwide vaccine. So what we are doing is we actually identify girls who has been vaccinated back then. And between these girls, some of them already have children.
Yeah.
So we are actually now trying to have them like talking about the vaccine, showing that they actually got pregnant, they have children. So I think at some point, as she mentioned, like human connection, also seeing their peers getting vaccine and actually having children, I think it can at some point break the barrier. So yeah.
Thank you very much. I'll take one last.
Yeah. I was next.
Oh, Latif.
I wanted to say I agree with everything everyone has said,
Okay.
but I wanted to say that sometimes, let's say in a primary school class,
Right.
when you make the noise maker the leader of the class, they control, you get better control of the classroom. Like let them take the names of the people that are making noise, right? So you said rumors spread on social media. Rumors don't start out of nowhere. There's people spreading rumors. So yes, we can take the community leaders and all that, but there's someone within the community that is spreading, that is starting that fire. There's no smoke without fire.
Okay.
So we had that situation when COVID started in our mosque in Malawi, where there was a religious leader who was against the idea of, because you know when you're praying, you're like shoulder to shoulder in a line, right? Who was saying no, against the idea that we should leave those 1 meter spaces. So he'd say, no, we cannot bring this innovation into the mosque, okay? And he had a large voice that he was listened to. Yeah, so instead of taking the people that agree with him to convince him, we actually took him to a COVID meeting. Okay. Yeah, for like a week.
Okay.
When he came back, he was the one advocating that we give the spaces, and if you can pray at home, pray at home. So sometimes you need to find the source and then empower those people with knowledge, because all these rumors come from fear.
Yeah.
Yeah. And fear comes from lack of knowledge. Yeah.
Thank you very much. I just want to take one last comment, and to make sure I don't get fired, please, I need to keep my job. I need to actually give this talk. So,
All right, thank you. Okay, I don't want to look down different comment here.
yeah.
But I've got the impression that most of the things are being proposed here. Okay, regarding myself, we've been applying it for quite years. You know, this thing of religious leaders, I don't know, traditional healers, we've been practicing them for years. Personally, in my district where I'm working currently, we've done almost everything. Almost everything. And almost 30% of the population, they're still reluctant.
They're still?
Reluctant.
Reluctant.
Hesitant. Okay. So as we are talking about innovation, good ideas, but I've appreciated the last comment from the colleague there. But you know, taking someone, bringing them, you know, bringing him to the meeting is not always easy. So I would like, actually, okay, if out of this, if we can think out of the box, as we used to say, I think we'll be having this think tank. So I really, really want to go out of what we are usually doing.
Yeah.
Out of these traditional healers, out of this chief.
So
yeah.
So let me say this. You raise an important point, and the one thing that we need to understand is that no one solution works for every context, and every context is different. But I'm glad that you're saying we need to think outside the box in terms of what would work, and I'm glad you brought up the think tank session, because this is all building up, in fact, to that. But I also really appreciate all the comments that have been shared. I'm hearing issues around being context specific, pooling people who have some kind of influence or buy-in with participants to basically just draw their attention. And I'm sure there are many, many other examples of innovative strategies that we could suggest for this particular scenario and many others. But as I said, I need to move on. Tony just told me I have 15 minutes. I'm not too worried because actually that was the scope of my talk. That's it. You've done the bulk of the work. But I'm sure I don't need to convince you in this room today that it's not business as usual for immunization programs on the African continent. In fact, it hasn't been business as usual for a very long time, way before COVID, and way before any other outbreaks that we're experiencing. But it certainly hasn't done us any favors, and this includes the funding cuts that we're experiencing. But make no mistake, the African region has achieved significant public health success in the past 5 decades of the expanded program on immunization. We've seen increased access to life-saving vaccines, significant reduction in VPDs, vaccine-preventable diseases. We're seeing elimination of VPDs like wild polio, near elimination of maternal and neonatal tetanus on our continent. And yet the continent continues to lag. We have just over 30 million children under the age of 5 who continue to suffer from vaccine-preventable diseases every year. And unfortunately, we lose about 500,000 of these kids every single year. And whenever I talk about this 500,000, I feel as if we're not really connecting with what that means. 500,000 every single year. I'm an avid football fan, but usually Chelsea ruins my weekends. But for me to be able to contextualize what 500,000 kids, losing 500,000 kids means, these are the 3 biggest stadia in Africa. And together, they hold just over 250, 260,000 people. So this is not even 500,000. So I hope that it makes sense to us that it's not right. And it's not okay to sit and have discussions. We need action, right? So the other thing that complicates things for us is we have disease outbreaks. We have over 150 cases of outbreaks and other public health emergencies happening on the continent every single year. And this leads to significant disruptions to our immunization programs. So at any given point on the continent, we're experiencing concurrent, cascading, nesting crises. It's either there's one crisis going on, like a conflict, or there's a climate-related issue. It's either there are crises happening concurrently, there's one crisis within another, or there's a new crisis around the corner threatening to break loose and just ruin great successes that we've already achieved. We also have core epidemics ongoing on the continent, HIV, TB, malaria, all of which are usually competing for the same money bag and the same human resources, which makes it really challenging to deliver immunization programs on our continent. We are seeing an increasing number of children living in conflict-affected settings, which is widening disparities and inequities. And we are also experiencing significant climate-related disasters, flooding, drought, and all of these are contributing to disrupted health systems and immunization programs. There's also the issue of resource limitation, or, following Prof. Ndembi's talk, perhaps it's more about poor governance than resource limitation. There's also the issue of increasing mis and disinformation, and all of these are adding complexities in terms of us being able to deliver immunization programs to services to those who need them the most. So very quickly, I know Dr. Farid already touched on the issue of humanitarian crisis and political crisis, so I'm not going to belabor that point, but I just wanted to buttress what he spoke to us about by highlighting the impact of COVID, as well as the impact of climate issues on our immunization systems. And so this here just shows us the global performance of routine immunization programs. You have the global in the blue, you have the African region, the Americas, EMRO, but you can see year on year kind of the dips and changes in immunization coverage using DTP3 over the past few years. And of course, during the COVID period, 2020 to 2022, we saw dips. Some regions are starting to recover, some not so much. Some are being affected by other crises or public health emergencies that have been ongoing. What I wanted to highlight with this particular slide is the issue of climate crisis in Africa. And you might not be able to see this perfectly, but just to mention that, you know, these slides will be provided at the end of today or at the end of the course. But it's to highlight how climate-related disasters contribute to disease outbreaks, but also contribute to disrupted health services and health infrastructure, and thereby compromising access to vaccines for those who need them the most. If we could take the DRC, for example, significant challenges in terms of disease outbreaks or epidemics, but also experiencing issues around flooding in some parts, at least at the time that this report came out, and also issues around storms, but there's also political conflict in some parts. So basically, ministries of health have to balance all these complexities in order to prioritize how they deliver immunization programs to those who need them the most. So I've provided some resources on the side, which you'll have a chance to look through once you have the slides with you. The point I'm trying to drive across is that our immunization systems are functioning in the context of prevailing public health emergencies. On the one track, you have the climate crisis and related natural disasters. On the other, you have humanitarian crisis and political conflicts. On another, you have pandemics, epidemics, and outbreaks. And all of these basically create a perfect storm of conditions for disrupted immunization services and outbreaks of VPDs. And so speaking about storms, we talked about resilient immunization systems. You all proposed excellent words in terms of what resilience means to you. The idea is the reason we need resilient immunization systems is the picture I've painted for you. It's business unusual. And we need resilient immunization systems to be able to manage crisis in real time and maintain provision of immunization services. My dear colleague, Dr. Elizabeth, likes to say that the best time to prepare for war is during a time of peace. And the best time to strengthen immunization systems is before a crisis even happens or before there's a public health emergency. Or next best time is after a public health emergency has happened, because we can draw lessons from that experience in order to strengthen and plan better and prepare once the next one comes, and they will come. So how can we achieve resilient immunization systems? Again, these resources are available to you. And from these resources, we understand the core features of a resilient immunization system. These are integration, adaptiveness, resource availability and access, self-regulation, and awareness. And these are terms that you also actually suggested. And basically with integration, we're talking about ensuring that we have strong cohesion across stakeholders, including those that sometimes we might overlook. There were suggestions about community leaders and religious leaders, but making sure there's cohesion across all stakeholders, and also good and strong communication. Adaptiveness means being able to respond, evolve from public health emergencies, and also learn. Resource availability, as you can imagine, is about ensuring that we have the right resources to continue to sustain immunization service provision. Self-regulation requires us to monitor and evaluate our systems in a way that generates data that will inform awareness, basically using that data for action. So I have a couple of case studies, but I think we did a really good job with the scenarios. But these examples come from some of our own country experiences. The first from Burkina Faso, in parts of the country that at the time were or have been experiencing terrorist attacks. And what they did there in terms of to ensure resilient immunization programs or service delivery is task shifting. So deploying community health workers, training them to go out into the affected communities to collect data, identify kids who might not be vaccinated, and link them to care. And based on the success of this, there were even considerations in including this in their national guidelines. Similar experience in Boko Haram affected parts of Nigeria. What they did was to engage with security forces and just basically partner with them to say, we understand that there are serious issues going on, but the community still need their vaccines. So can we come on this day and be able to enter these communities and deliver those vaccines? And that, in a sense, ensured that they were still able to continue with their polio vaccination campaigns. In South Africa, I have an example from the COVID period. In some parts of Cape Town especially, we basically converted ambulances into what they called vaccine taxis. And they went out into communities who could not be reached by COVID-19 vaccines, but even other healthcare services because of the lockdown. And they delivered those services to those communities. So the cross-cutting theme across this is basically bringing the services closer to the communities, and in so doing, ensuring that you have a resilient immunization system. So in terms of advancing vaccines and immunization landscape in Africa, we have to think about innovation. And despite the disruption caused by the COVID-19 pandemic, it also became a catalyst for innovation. We have proof of concept for mRNA vaccine platforms. We can now consider the potential of having a vaccine within 100 days in terms of vaccine development. And it also forced us to pivot from how we communicate about vaccines and how we develop policies. So really bringing in some level of innovation in terms of how we work. But the question is, did that contribute to innovations in our social contexts? And I think to some extent, most likely not, because we are seeing still some significant knock-on effects of mistrust and misinformation, especially after the COVID-19 period. So the call to action here is basically to leverage the lessons learned during the COVID-19 pandemic to be able to strengthen our immunization program. I think we've done some of that, but there are still some important gaps that we need to strengthen. And hopefully during the course of this week, we will be able to come up with some solutions towards that. So how can we achieve innovative immunization systems? Well, the essential features of an innovative immunization system includes simplifying logistics, and I think our colleague Latif made a suggestion towards that, increasing effectiveness and safety and acceptability of vaccines. A good example is the micropatch that I think Greg was also mentioning. You know, how do we enhance acceptance of vaccines for those who might have real fears? Enhancing equitable access to vaccines and minimizing missed opportunities for vaccination. So in terms of examples of innovation, there have been many across the African continent. Use of drone technology to deliver vaccines to hard-to-reach areas. In Rwanda, establishment of a digitized electronic system, not only to collect immunization data, but also health data. And then in terms of communication, we have a good example from a research project in Tanzania where they leverage storytelling and concerts and sports events to better engage communities and to strengthen vaccine acceptance and uptake. So if you could innovate one thing in Africa's immunization landscape, what would that be? And you have a smile on your face, I'm going to go with you.
I will create an app who can help to take fingerprints of all children, and then we'll know if the child received vaccine or not. And based on those data, we can reach zero dose
We
children.
can reach zero dose children. So strengthening our health information systems.
Thank you so much. And thank you for the presentation. I'm thinking, you know, we have this organization, the civic society organization, and most of the time it's used by the TB and HIV program, which is, we are too silent as vaccine or immunization ambassadors. And even in our meetings, it's only us talking to us. So we don't invite those people that can go out there and be ambassadors of the vaccine. So I think it's time we need to pause and say, who do we invite? As much as we are here for knowledge gain, I think they will have a great impact as they go out into our communities. Thank you.
Very good contribution.
I think we need to emphasize the role of social media and media. And for example, if people show, for example, her their favorable movie stars, for example, take the immunization and you feel, for example, the media and favorable movie stars who can take the vaccine and after that he feel safe and I think this is will make an fast information message for the people.
Okay, so bringing on trusted influencers. So that would be your innovation.
Influencers, social media,
Okay.
Movie stars. I think we need to rebuild the accurate position for the media.
Okay. Okay.
There's an online comment here about electronic immunization registries. In other words, having person-level data, not aggregated data.
Yeah.
Or in addition to.
Yeah, so I really like that suggestion, and I think in other forums it's been about also not just for kids. It should be lifelong. We should, you should be able to find out if you actually received your measles as a kid. So lifelong immunization systems. Any other innovation? One last innovation. Okay, it's gonna come in the think tank. All right, so I'm wrapping up. So if you had to ask me, I foresee a very positive outlook in terms of Africa's immunization system. Not only because VACFA is training vaccinologists such as yourselves who will go out back into your countries and your communities to make lasting changes and revolutionize the immunization landscape, but also because there is evidence to suggest that there are ripe opportunities to innovate in our context. So I think we've made significant gains, but there are some very persistent and some very real setbacks to immunization systems in Africa. And this basically underscores the urgency for investing in resilient and innovative immunization system. The question is, what works for your context? And you'll only understand that by actually doing the work. The vision for the future of immunization systems in Africa, for me, as I said, is a positive outlook. And in terms of shaping a resilient future together, it requires a whole of systems approach. It doesn't just take vaccinators, it doesn't just take politicians, it doesn't just take influencers or religion, it needs everybody on board. And I think that comes back to the point you were raising about expanding the group of stakeholders and making sure that we better engage all collaborators. And so with that, I will stop talking here, Tony, and hand back to you.
Thanks so much, Sadina. Thanks for a lovely lecture. And well, one of the reasons that it was such a great lecture was that Edina's weekend was not ruined because Chelsea actually won. They beat Spurs, yeah. All right, are there any, we got a couple of minutes. Are there any other questions just to wrap up, follow up? No, you're all good. I think you should all stand up. Okay, just let's take one here.
Thank you so much, Adina, for the great presentation. I just want to flag something. I don't know if the colleagues have experience. When we come to integration and how gender is missed. I was the gender focal person as well where I'm working. So we need to know, is there any barriers that are related to gender that making children not to be vaccinated? And we have little desk information about that, basic information about that. We have assumption in our mind about the power dynamic. Men are the one responsible, have decision-making activities. But when we went outside for this exercise, we realized the power dynamic is different. We have household that are polygamous household, where the first wife is the one taking control of everything, and then she's the one now giving orders to the other wives. The mother-in-law have a lot of impact on immunization, especially because some decision are women decision. Child caring is a women decision. So women make that one. And women are neglected when people are talking and having conversation. we immunization, how our mobile teams are going to the fields. You are going when women are very busy doing their housework. Can we change that? Can we go when women are convenienced, can come to the, you can take it up to their household door and they still not come. So you have to come when they are comfortable enough. They finish all the housework, usually noon time. This is what we realize. In the morning, she's fetching water, she's preparing breakfast for the husband, whatever. But when you come in the afternoon around 1, 2, she relaxed. Now she's going to rest for a bit and then start dinner or whatever. So come in that time, she'll be okay. Don't come when she's busy. African countries, we know ourselves, we have food distributions. During that time, is it even effective to go for outreaches? No, because nobody comes. It's waste resources. So I think the gender aspect of immunization is neglected as well.
Yeah.
There's little information about it. And this is something that we need also to think about when we are planning or doing these immunization projects that usually don't reach to anybody if we did not consider some aspect like gender and all. Thank you.
Yeah, I really agree with you, Fatima, and I think some really strong points that you're raising. And I think it also comes down to understanding the context within which you're working, and making sure that it's not just about designing immunization services and just delivering it to the people. You need to understand their context, use that to inform, or even have them be part of the design, so they can tell you, you need to come at 6. But the issue of gender is also really important, and it comes into play during HPV vaccination programs. And I'm not going to talk too much about that. I'm looking directly into Fumani's eyes, because I think she may raise that when we talk about HPV vaccination programs, but really strong, important points. Yes, Anele.
Hi, thank you very much, Adina. I'll be very quick in the interest of time. There's a comment made by some colleagues in terms of how we can get vaccine acceptance by engaging maybe celebrities and the social media and all. I feel a bit indifferent about that, partly because I prefer, or I would rather have someone who's knowledgeable about the subject to educate the public about vaccines and everything associated with vaccines, and also influencers and celebrities as a brand. They can oftentimes have way too polarized group of individuals who follow certain influencers.
Okay.
So I just think personally, if we need to disseminate any information pertaining to vaccines and the science around it, we have capable professionals who are knowledgeable about the science and the vaccines to be the ones who be at the forefront to educate the public about that.
Yeah.
I mean, that also extends to even politicians or government officials who want to go on public platforms and educate the public. So rather have educated, competent healthcare professionals to take on that
To do the
responsibility.
communication.
Thank you.
No, that's a useful point. It's a very important point, and I think what you're raising is saying we need to use those influencers or those leaders appropriately. They might have a role to play, but not to actually communicate science, for example. But they might have some kind of influence. But I'm wondering, Anele, given that you are a scientist, does that have a role to play in terms of who you would listen to, for example?
You have to turn it into a social influencer.
Can I?
Yes.
Sorry, was you?
May I?
Oh,
Yes.
okay, carry on.
Just kind of contrary to what you just said. There are, I think this is exactly what's happening. Some of us scientists, well knowledgeable people, happens to be on the other side.
Yeah.
So now to you, how then do we deal with such a scenario? A very educated person, influential person, is on the other side.
Is on the other, you mean is hesitant?
Yeah. It's gone over to the dark side.
I mean, do we, I don't, well, I was about to make a bad example because I'm not sure if we should call RFK and
No, he's
he's not.
person.
He's not a
knowledgeable
scientist.
person.
He's not a
Yes.
scientist. He's a moron.
He's a moron.
Yeah. All right. I wanted to share this really, really good comment online from Cornelius Chebo. I'm not sure where Cornelius is. JP, do you know? Anyway, Cornelius says, we had a situation during an outbreak of measles in one of our health areas. There was a lot of resistance. And on further investigation, we discovered that there were many zero doses, and some of these children as old as 8 years, which is when the socio-political crisis started in my region and became an armed conflict. We had to use armed actors whose children contracted the disease with the traditional leaders to help pass the message before we could have access to the children. I mean, that sounds pretty hectic. All right, and then there's a question here for you, Dina. How can we bring the use of AI into innovative immunization systems in an African setting?
I was afraid this will happen. Oh God. Okay. I mean, the reason why I was afraid this will happen is because it was a point that was raised by last year's participants where they said we need to start to integrate discussions around leveraging AI. The first thing that comes to mind to me is on our information systems. How can we bring to reality what was being raised by the colleague in terms of coming up with more effective data systems or health information systems that would allow us to be able to access the data that we need at the time that we need it, in the format that we need it, in order to immediately act on responsible or related issues. When it comes to science communication, I'm not sure if that's the route we need to go yet. But I don't know if anybody has any other suggestions in terms of better integrating AI or leveraging AI in current immunization systems. Ines, you.
Yes, thank you, Edina. Actually, I have 2 points to reflect on with you and to discuss if possible. The first, like I join my neighbor in this comment, we tend to discuss in us as a health system, health professionals, and them as the community, our people. And we tend to forget we are the people. We represent our communities. How can we be credible and lead by example if the gatekeepers we have hesitancy, we have anti-vax among us, doctors, nurses, WHO, even, I'm telling you, my colleagues, some of them are hesitant, and it's a reality, but we tend to believe that this is an assumption. We health workers are advocates, and the community, we need to reach the community. If ourselves understand better why some people tend to think that this is harmful or we should not go for vaccination, better understand it, embrace it, face it. It is there. Absolutely. And we need to work on it. This is my first idea, because it is really harmful when we see communities, see doctors and nurses against vaccination. If people who are working in the immunization programs are not following or abiding by what they say and doing what they say, why we people will believe them and do the same? It's kind of confusing for the population. The first point. My second point is disinformation. I'm not saying only misinformation. It's even disinformation for political reasons. It is here with new game rules. Social media tend to polarize, algorithm polarize opinions and make that the most conflicted and controversial ideas and videos emerge, and it is here to stay. Next generations are more and more hesitant. They consult the social media. You say traditional leaders, okay, but the younger parents are, the more hesitant they are. So we have to understand that, and it is part of our reality now. We need to understand how it works and educate people about it. Maybe we're not ready to leverage AI, but we need to understand how AI shape our world and make people understand how their consent is manufactured for or against things.
Yep.
Because if people don't understand, they don't follow. It's not like we cannot continue by having vertical attitude towards them, and like we talk to them about their health. They have to understand how their decision making is influenced by bigger things than us and them, and
give them the option to choose.
Yeah.
Thank you.
Thank you for that, Inez. And I think the first point definitely relates to what you were raising. What happens when the people that are meant to be delivering the immunization program or other healthcare services are in fact on the hesitant side, and how do we go about addressing it? And I think I'll bring it back to the morning. It might seem like it was a joke, but Prof. Ben did ask the room, do we have any hesitant people? Because we assume that we're all here and we're all on the same board, but there might be some of us who have some concerns about some vaccines, maybe not all. I'm not going to ask who received all their COVID-19 vaccine doses because we might have to book flights, but but I think it's a very important thing that both of you are raising, because these are people that communities trust to help them make informed decisions about their health. And when they go on the opposite side, they make lasting and damaging impacts on people's decision making. And I mean, we will have Haneli, who is the queen of vaccine confidence and hesitancy. And I believe, Haneli, that the rules apply the same in terms of how we engage the healthcare workforce that are hesitant or denialists. There are some that we might not be able to change their minds, but we need to figure out how we can empower communities to still know who to trust and who to rely on. Because we get many questions around, oh, my doctor said I don't need a COVID-19 vaccine, even though I'm pregnant. They don't trust in that. But how do we go about changing those who might still be amenable, And I think one of those is these forums like these, where we have healthcare workers all sitting together, or people working in the immunization program all sitting together, and we're trying to get on the same board. And it's about training, continuous training. I can take the example from South Africa, where we now have a knowledge hub led by the Ministry of Health that tries to put out, weekly webinars to engage healthcare workers. And these are some of the conversations that, are brought up during those knowledge hubs. And they're very helpful in engaging thousands and thousands of healthcare workers around some issues that they might have concerns about. But it's a real problem. And I think in Tunisia, it has contributed to the HPV vaccination challenges that you're seeing, because there are healthcare workers in Tunisia who unfortunately are perpetrating some of these mis and disinformation. And we've seen similar issues in Nigeria and other parts of the continent. So a very good point to raise.
1 minute, one question.
For me, it's not really a question, it's the comment. I think she has touched on a bit about the trust. I think there is a disconnection between the community and the healthcare workers. I'm gonna say this as at least as a healthcare worker before I became who I am today. Most of our patients, or let me say generally our clients, have lost a trust in the healthcare system, and also they have lost a trust in the experts, people who are supposed to make them informed, to re-inform, or to capacitate them about all these conditions. I think we will need to have a constant communication or constant interaction, that is community engagement with our communities before we talk about vaccine, about it, and also immunization. So just we build on, so that whenever if they've got a myth or misinformed, or they don't have something that they don't understand, we're able to re-engage them and equip them that this is not how things are the way they are. We change their mindset regarding all this misinformation that they are getting from the community, because healthcare workers are the key point. They are the entrance to the community. They are the ones who are supposed to deliver these vaccines and they do these immunizations. So we need to make sure, or even we need to make sure that the healthcare workers, they are well capacitated and able to strengthen also the community based on this misinformation. I think that's my take. Thank you.
Thanks so much. Good comment. Let's have a big round of applause for Adina. We'll let the lecture. Okay, I think we're onto the home straight. So next up is Petronella. And as she comes up, I need to teach you. Can you all say after me, usuku? You say that? Usuku. And Loku Zalwa. Loku Zalwa. Usuku Loku Zalwa. You all got that? Okay, it goes like this. Usuku Loku Zalwa. Usuku Loku Zalwa. Usuku Lutle Kuwe. Usuku Loku Zalwa. Was that correct? It's Petronella's birthday today, so we wish her a very, very happy birthday.
Thank you, everybody. Thank you, Tony. Okay, so my job here is very simple. I'm here to appeal to you and to emphasize that as a team, we're very big on learning, we're big on reflection, we're big on improving, and we're big on being able to adapt, right? So because of that, we cannot do it without the feedback that we receive from you. So that's why I want to appeal and say, please, would love to have at least 100% on our survey responses. So if you can, please make sure that you fill in the survey from today onwards up until Friday. Is that a yes? Thank you so much. I hope people are not saying yes because it's my birthday. Okay, so, all right, I think you're all familiar with WhoClap now, so please scan the QR code and put the access and enter the code. Are we all in?
Not yet. Wait.
Are we all in? Not yet, okay. Oh, wait, this is my. Can we move on? All good? Not what? All right. Yeah, it says there's no vote in progress at the moment. Yes, because we haven't started. So we're gonna, yeah, so yeah. We don't put the code in. You can put the code, but I think the questions will come up as I move the cursor here on my side. Yeah. Okay, should I? Okay, so the first question is, which country are you from? So we can start filling in. Awesome, South Africa seems to be dominating. Okay, 66 participants filled in. Okay, we're gonna move on to the second one. So now we're rating the sessions. How useful was the information presented in the session on an immunization agenda for Africa, past, present, and the path forward? You can vote on mostly what I learned is important to me and I'll apply it, or what I learned is interesting, but I don't think I'll apply it that much, or some of it is useful to my work and some not. Okay, on to the next one. How relevant was the session on introduction of new vaccines, progress, public health impact, and policy considerations? Okay, still waiting for more people. Most of you found it important. Okay, moving on to the next one. How insightful was the session on regional priorities for immunization in Africa, advancing self-sufficiency in a changing global landscape? Still waiting for more people. Only 70 have completed after, out of 87. So please try and complete. Thank you so much. Okay, please rate the presentation on immunization during crisis, navigating humanitarian conflict and climate challenges. Did you find it very useful, or not useful? All right, moving on to the next one. How informative was the talk on resilience and innovation, building stronger immunization programs in Africa's dynamic landscape? All right, the next question. Please list anything new that you learned that you think is applicable from the sessions from today. Anything new that you learned that you think is applicable from the session today, from the different sessions today? Seeing a lot on resilience, innovation, hexa vaccines, new vaccines, different strategies applied on immunization. All right, moving on to the next question. What do you think worked well in the webinar session, in the sessions